offering safer, more effective solutions for arrhythmia patients. Our care does not end in the operating room. We support every patient's recovery through cardiac rehabilitation programs such as Heart Gym, enhanced external counterpulsation combined with the most advanced imaging facilities, including single-photon emission computed tomography, dual-source multi-slice computed tomography, magnetic resonance imaging, fetal echocardiography, transesophageal echocardiogram. All of these are integrated with comprehensive cardiovascular medical checkup, hemodialysis, palliative care, ensuring that every patient receives holistic, compassionate support at every stage of their healing journey. As a teaching and research hospital, we serve as a national center for the advancement of cardiovascular medicine. Through collaborations with University of Indonesia and hospital-based cardiology residency program, with scientific research, publications, and patented innovations, we contribute to shaping the future of medical science in Indonesia. We also serve as the hub of the National Cardiovascular Network, developing and strengthening standards of care for hospitals across the archipelago from Sabang to Merauke. Our journey of transformation continues with smart building automation systems, modernization of kitchens, laboratory, central sterile supply department, and pharmacy. Along with the expansion of educational, nursing round, and research facilities. Through decades of dedication and commitment, we have received numerous national and international awards, a true testament to the quality, safety, and integrity of our care. And now, the construction of the Tokushukai building marks another milestone in our journey, a new symbol of progress and collaboration, bringing future-ready facilities to serve the next generation of patients. We are the National Cardiovascular Center, Harapan Kita. More than just a hospital, we are the center of hope, a place where life is given a second chance.
Keep believing in giving hope with a commitment to serve across generations.
Thank you, ladies and gentlemen. We will now continue with the next agenda.
It is an honor to invite the President's Directors of National Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, to deliver the welcome speech. Dr. Iwan Dakota, the stage is yours.
Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera, Om Swastiastu, Namo Buddhaya, salam kebajikan, salam sehat untuk kita semua. Selamat datang Bapak Ibu sekalian di Indonesia International Cardiovascular Summit. Hari ini senang sekali hadir bersama kita Bapak Menteri Kesehatan Republik Indonesia, Bapak Budi Gunadi Sadikin, Bapak Wakil Menteri Kementerian Dalam Negeri, Bapak Bima Arya Sugiarto, Bapak Sekjen Kementerian Kesehatan, Bapak Kunta Wibawa Dasanugra, Ibu Dirjen SDMK, terima kasih Bu Yuli, Ibu Ketua KKI, hadir juga Ibu Arianti, terima kasih. Dirjen Keslan diwakili oleh Direktur Yanklin, Pak Obrin, Direktur Fasiankes, Pak Gotama juga hadir saya kira di sini. Kepala Badan Kebijakan Pembangunan Kesehatan, Prof. Asnawi, terima kasih sudah hadir. Kepala Puskes AD, Dr. Birma Wisnu Nugraha, seperti itu para Dewan Pengawas, kemudian Bapak Ibu sekalian yang saya tidak bisa sebutkan satu persatu, distinguished guests. I think that we have a lot of the international faculty coming from 9 countries. I'm so sorry, I should speak both in bahasa and English. Sebagai laporan Bapak Menteri Kesehatan dan Pak Wakil Menteri Dalam Negeri, kenapa kami undang sebenarnya Pak, alasannya ada SKB 3 Menteri waktu itu Pak, untuk program pengampuan penyakit prioritas, diantaranya adalah penyakit jantung dan pembuluh darah. Dalam SKB 3 Menteri, itu yang ditandatangani oleh Bapak Menteri Kesehatan, Menteri Dalam Negeri, dan waktu itu Menteri Keuangan, yang intinya kami akan melakukan pengampuan yang hampir semua, lebih dari 90% rumah sakitnya adalah rumah sakit bukan milik Kementerian Kesehatan, tetapi milik dari Pemkot, Pemprov, Pemkap, barangkali yang wilayahnya memang domain Kementerian Dalam Negeri. Bapak Ibu sekalian, hari ini adalah acara annual scientific meeting, acara tahunan ilmiah penyakit jantung dan pembuluh darah. Sebenarnya ini arahan dari Pak Menteri Kesehatan. Waktu itu kita ditantang. Kalau ada di luar negeri, itu ada di Turki kalau saya tidak salah, ada acara tahunan di mana yang didatangkan ada 10 barangkali minimal top 10 kardiologis atau cardiac surgeon. Kenapa kita tidak bisa buat di Indonesia? Saya tantang seperti gitu. Buat seperti Jack Jazz katanya, yang memang nanti para ahli musik dunia akan hadir di sana. Jadi ini tantangan ini sudah kami jawab. Alhamdulillah Pak Menteri sudah tahun ketiga kita melakukan acara ini, dan alhamdulillah acara hari ini tercatat lebih dari 800 peserta yang datang hadir di sini. Belum lagi yang mengikuti teman-teman dari seluruh Indonesia, dari 514 kabupaten kota, 569 rumah sakit di bawah pengampuan kami itu akan hadir mungkin lebih dari 1000 peserta dari seluruh Indonesia. Bapak Ibu sekalian, izinkan saya barangkali menyampaikan penghargaan yang seterusnya kepada Kementerian Kesehatan atas arahan yang berkelanjutan, Pak Menteri Kesehatan, kemudian dari Kementerian Dalam Negeri yang telah begitu banyak sekali membantu kami menjembatani dengan Dinas Kesehatan setempat, rumah sakit milik Pemprov, Pemkap, dan Pemkot. Ucapan terima kasih juga kami sampaikan kepada semua pihak yang memberikan kontribusi, mulai dari Bapak Gubernur DKI Jakarta, barangkali ada Pak Aditeng Project yang kami lakukan di sana, kemudian dari Kepala Pusat Kesehatan TNI AD, Kepala Pusat Dokes Polri, Ketua Umum Perki, saya juga lihat hadir di sini Ketua Kolegium Himpunan BTKV juga hadir di sini, Kolegium Jantung Perdatin, Kolegium BTKV juga hadir, dan Yayasan Jantung Indonesia yang hadir, dan juga wakil dari Yayasan Harapan Kita barangkali juga hadir di sini. Saya juga memberikan apresiasi yang setinggi-tingginya kepada tamu international faculties which is coming from Japan and some other Asian and European countries. So we would like to extend our appreciations for your contribution in our annual scientific meeting. Sebagai laporan Pak Menteri, selain peserta para international faculty, saat ini ada dari 10 negara. Peserta juga bukan hanya dokter jantung dan dokter bedah, ada juga perawat, bukan hanya berasal dari dalam negeri juga, ada juga teman-teman dari negara tetangga juga hadir, dari Myanmar, dari Kamboja, yang juga hadir untuk mengikuti acara pada hari ini. Tadi jam 8.15 tercatat 783 peserta. Barangkali sekarang sudah lebih, dan kami mengharapkan ke depan ini bisa lebih banyak lagi peserta yang hadir, dan kami membuka hybrid dengan membuka online yang akan diikuti oleh teman-teman dari 514 kabupaten kota. Saya kira misi ini selaras dengan transformasi kesehatan yang sedang berlangsung, di mana penyakit jantung dan pembuluh darah masih menjadi penyebab kematian tertinggi, dan yang kedua, spending a lot of money, katanya paling tinggi untuk dana yang diambil dari skema BPJS. Kami mengharapkan melalui kegiatan ini akan mengeksplor perkembangan terbaru dalam bidang kardiologi, baik bedah maupun intervensi non bedah. Beberapa sesi bukan hanya sekedar diskusi ilmiah. Pak Menteri, kami laporkan, kami juga mengundang rumah sakit. Kami akan melakukan monitoring dan evaluasi terhadap apa yang kami lakukan setiap tahun, dan ajang ini juga akan dilakukan ajang untuk melakukan menerima masukan dari beberapa rumah sakit jejaring kardiovaskular nasional, dan ini melibatkan Kementerian Kesehatan dan beberapa direktorat, di mana Rumah Sakit Jantung Harapan Kita sebagai pengampu jejaring kardiovaskular nasional. Pak Menteri, pada kesempatan yang baik ini kami juga ingin meluncurkan buku sejarah Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita yang berjudul Melayani Nusantara Menggapai Dunia. Buku ini bukan sekedar dokumentasi perjalanan institusi, melainkan juga sebuah refleksi atas dedikasi, inovasi, dan keteguhan komitmen yang telah mengantarkan para founding father. Saya kira ada di sebelah kanan kami, mohon berdiri Bapak Ibu sekalian, founding father Rumah Sakit Jantung Harapan Kita, kami undang di sini untuk peluncuran buku ini. Para senior yang hadir di sini, beliau-beliau inilah yang menjadi narasumber utama dalam penyusunan buku sejarah Rumah Sakit Jantung. Kami mengucapkan terima kasih. Izinkan kami menyampaikan rasa hormat dan terima kasih dalam-dalamnya. Pada kesempatan yang baik ini, kami mengajak semua peserta yang hadir untuk terlibat penuh mengkritisi berbagai gagasan, kita berbagi pengalaman membangun kemitraan baru, dan membawa peluang wawasan yang dapat mentransformasi praktek memperkuat institusi di daerah masing-masing. Semoga acara ini tidak hanya memantik inspirasi, tapi juga meneguhkan tanggung jawab kita bersama. Dengan ini saya resmi menghimbau, menyambut Bapak Ibu sekalian pada acara IICS ketiga pada tahun 2025. Mudah-mudahan bisa mendapatkan hal yang terbaik yang bisa didapatkan untuk dibawa ke daerah masing-masing. Terima kasih, dan semoga kesempatan memberikan inspirasi serta mempunyai dampak yang bermanfaat. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much to Dr. Iwan Dakota for the meaningful opening remarks and comprehensive report.
Ladies and gentlemen, we now invite the Minister of Home Affairs of the Republic of Indonesia, represented by Deputy Minister of Home Affairs of the Republic of Indonesia, Dr. Bima Arya Sugiarto, to deliver his keynote speech. Dr. Bima Arya, the stage is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon us all. Salam, Om Swastiastu, Namo Buddhaya. Your Excellency Minister of Health, Bapak Budi Gunawan Sadikin, Your Excellency the President Director Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, Your Excellency Specialist Medical Personnel, health workers specializing in health in heart and blood vessels, and distinguished ladies and gentlemen. First of all, allow me to convey the warm regards from the Minister of Home Affairs, Bapak Profesor Tito Karnavian, for not be able to join with us today here because he has to attend some state agendas in Tangerang and also in Bali. It is really a great honor and privilege to stand before you today at this important gathering that marks the third Indonesia International Cardiovascular Summit. And allow me to extend my deepest appreciations to the big family of Rumah Sakit Harapan Kita, and also to warm welcome to all participants, all delegates, especially our distinguished guests from abroad who have traveled far to be here today to join at this very important event. Bapak Ibu, ladies and gentlemen, Indonesia is a very vast and diverse nation governed under the principle of regional autonomy. Today, we have 38 provinces, 46 regencies, and 98 cities. And we knew that regional autonomy plays a very significant role in strengthening the quality of public service in Indonesia, including, of course, health services. Local government is now serving as the frontliners of the public service delivery, including the health sectors. Local government are the closest institutions to the people. And the performance of local governments, the performance of Bupati, Wali Kota, and Gubernur directly affect the quality of life of the people at the regions. So, at this logic, the Ministry of Home Affairs strongly committed to fulfilling its mandate, overseeing, guiding, observing, facilitating, and of course, ensuring the local governments that can perform their duties effectively, doing the innovations and making collaborations with any stakeholders at their respective regions. Bapak Ibu, ladies and gentlemen, as we know, the cross-sector synergy is actually very important in generating innovations that will improvements to the public services. In this regard, one of the forms of synergy that is beneficial to community is marked by the existence of the Memorandum of Understanding, of the MOU, between the Ministry of Health, the Ministry of Home Affairs, and the Ministry of Finance regarding the accelerations of the synergy of the National Network Hospital Program. This document is intended as basis for accelerating the synergy of National Network Hospital programs in accordance with the authorities, duties, and the functions of the parties, by paying attention to the provisions of law and regulations. Then the purpose of the Memorandum of Understanding is actually accelerating the network hospital program that can provide health services for the community for the treatment of catastrophic diseases in the regions, and also to provide support for the allocations of funding for the National Network Hospital Program. And starting from this memorandum, I am confident that the quality of the health services, including services related to the heart and blood vessels, can be improved. Bapak Ibu, ladies and gentlemen, distinguished guests, the quality of health services urgently needs the support of qualified infrastructures and human resources. According to the data from the National Ministry of Health, Indonesia is currently has in total 3,278 hospitals. And of this total, there are 13 special heart hospitals and network hospitals for cardiovascular services support in Jakarta, West Java, Central Java, South Sulawesi, and Southeast Sulawesi. And we are really aware that Pak Budi Gunadi Sadikin has been trying so hard, focus on the improvement, not only the quantity of the health services, but also the quality of health services. Bapak Ibu, ladies and gentlemen, we are now facing so many challenges in the health sector. The low access and the quality of health services, inadequate health infrastructures, the uneven number, quality, and distributions of health human resources throughout Indonesia, kekurangan tenaga kesehatan, tenaga medik di seluruh Indonesia, the prevention of infectious and non-communicable diseases, climate change, and environmental degradations. And for this reason, collaborations, integrated cooperations among stakeholders related to health services is a must, is very important. And as an effort to answer these challenges, the Ministry of Home Affairs has provided policy support in the health services providing sectors, such as the implementations of free health checkup, adjustment of regional revenue, and expenditure efficiency in 2025, and the notification of free health examination target data. Ladies and gentlemen, on this occasion, there are several things that I can convey to be our common concerns. First, National Cardiovascular Center Harapan Kita, as the coordinator of the Heart and Blood Vessel Service Support Network, has the responsibility to provide services in line with the development of science and technology. And for these reasons, human resource competencies, as Pak Iwan Dakota has mentioned before, need to be consistently improved. Second, regional governments may continue to improve the quality of health services, especially cardiovascular, including strengthening minimum service standards, regional hospital governance, and also the integrations of digital health system in their respective regions. And lastly, the Ministry of Home Affairs is now committed to supporting the network hospital support program implemented by the Ministry of Health in the form of regulations for all regional governments, all regions, and all cities to be able in preparing policy support and budget allocation in their respective APBD or local budget. Bapak Ibu, ladies and gentlemen, may Allah Subhanahu wa Ta'ala, God Almighty, always provide guidance and protections in our efforts to build the nations that we love and improving the quality of health services, not only in Jakarta, not only in Jawa, but also throughout Indonesia. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Bima Arya Sugiarto, for your insightful keynote speech.
Ladies and gentlemen, we now welcome the Minister of Health of Republic of Indonesia, Mr. Budi Gunadi Sadikin, to deliver his keynote speech. To the Minister, the stage is yours.
Bapak Ibu sekalian, selamat pagi, ladies and gentlemen, good morning. Saya pertama mau ucapkan selamat kepada Rumah Sakit Harapan Kita yang sudah melaksanakan acara ini untuk tahun ketiga luar biasa. So congratulations for Harapan Kita. Saya juga ingin ucapkan selamat kepada para pendiri yang sudah melihat mungkin harapan kita sekarang sudah jauh lebih maju dibandingkan harapan kita masa lalu. Yeah. Congratulations to harapan kita, and also thank you for all the person that established harapan kita from the beginning. Harapan kita, saya punya pesan gitu sejak saya selesai urusin COVID. Yang pertama, harapan kita harus bisa menyelesaikan masalah kesehatan jantung nasional. Ya. Karena secara nasional data yang tercatat ya, itu 250,000 death every year, 250,000 ya. Saya nggak tahu apakah data ini benar apa enggak, itu sebabnya data registry jantung itu saya minta harapan kita coba bantu diberesin ya. Indonesia very poor in data registry. Cancer juga registrinya mudah-mudahan udah kerja 2 tahun 3 tahun mungkin baru selesai tahun ini gitu ya. Mother and child mortality juga data registrinya kita jelek sekali. Jadi saya harapkan harapan kita can take a lead in finalizing data registry on heart disease gitu ya. Nah, kalau saya bandingkan dengan data dunia, kematian jantung itu sekitar 20 juta per tahun ya, 20 juta per tahun. Ini mungkin 20-25% dari data kematian. Di Indonesia datanya 250.000, banyak yang bilang ke saya ini mungkin total cardiovascular itu 30% dari overall death di Indonesia. Jadi memang ini kenapa buat saya sangat interested to be involved, karena ini adalah penyebab kematian tertinggi. Sehingga prioritasnya di mata saya naik paling atas. Karena kita bisa mengatasi ini, kita akan mengurangi kesengsaraan masyarakat kita. Ya, itu sebabnya saya put a lot of attention untuk Rumah Sakit PON dan Harapan Kita, karena penyebab kematian tertinggi, cause of death highest-nya itu cardiovascular. Nah, strateginya apa? Yang saya minta Harapan Kita bantu kawal. The first one, gitu kan, untuk semua penyakit sebagai Menteri Kesehatan, it's very clear I want to keep my people healthy, gitu ya. Jadi strateginya, mohon maaf, is not only to cure sick people. Itu sebabnya saya minta juga Harapan Kita untuk mengawal program cek kesehatan gratis Indonesia. Ya. Data yang saya lihat sampai sekarang sudah masuk 59 juta. So 59 million screening itu is already in our system since 10 February 2025. Dan speednya sekarang 500.000 per hari. New screening data itu masuk. Yang saya lihat ya 13-15% hypertension gitu kan. Diabetes itu 9-10%, kolesterol mungkin ada 3-5% dari targetnya. Nah, ini adalah our first strategy. Sekarang datanya sudah masuk, saya minta ke Ibu Nadia pastikan Harapan Kita mesti ngatur protokol dari tata laksana pemberian amlodipin, pemberian metformin, pemberian statin ke jutaan. Ini kita ngomong jutaan, puluhan juta orang loh. Ini harus jalan. Sehingga mereka bisa kontrol. Mereka terkontrol. Ini strategi yang paling bagus. Bukannya saya mau merendahkan ahli dokter bedah, ahli pasang ring segala macam. Tapi saya jamin nggak akan cukup itu cath labnya, dokter bedahnya kalau kita tidak membereskan and put the very clear priority to keep our people healthy and punya control patients dari hypertension, blood sugar sama kolesterol. Ya. Jadi next year saya mau make sure harapan kita work with Ministry of Health, make sure kita bisa kontrol 25% of this berapa? 15 juta, 20 juta orang yang memang memiliki risk factor untuk cardiovascular diseases. Itu first priority. Make sure bahwa hypertension, blood sugar, diabetes of more than 10 million Indonesian people yang sudah teridentify di free screening program itu kontrol dengan pemberian obat-obatan yang tadi saya sebutkan, murah and free, bisa available in semua 10.000 puskesmas. Nah, program yang kedua yang harapan kita masih hutang ke saya adalah memastikan pilot project untuk kombinasi deployment dari ECG ke 10,000 puskesmas dan standar protokol untuk memberikan 10 hektoplase itu jalan. Ya, kita udah jalan tahun ini, the result is not good. Ya. Karena tetap dokter-dokter umum yang ada di puskesmas merasa khawatir, nggak yakin, nggak pede untuk memberikan 10 hektoplase. Padahal kalau kita sudah bisa pastikan ECG itu dibagikan, diajari dengan baik gimana baca ST elevated dari apa tuh KLMPQ segala macam itu, kemudian mereka yakin ini ada heart disease potential, itu langsung disuntik aja sekali. Dan kita sudah menyiapkan anggarannya untuk memastikan instead of streptokinase atau alteplase kita kasih 10 hektoplase biar gampang sekali suntik. Nah, tugasnya harapan kita adalah mendidik 10,000 GP, 10,000 primary care untuk feel comfortable and confidence gitu ya, untuk bisa melakukan trombolisis ini at 10,000 puskesmas. Karena ini akan reduce drastically and buy a time to save life sebelum kita lakukan itu yang lain. Jadi ini strategi nomor 2 yang belum selesai, dan saya minta harapan kita mengawal agar secara nasional program ini jalan. Nah, baru kemudian strategi yang ketiga. Kalau kita bisa jalan 1 dan 2, kita akan reduce drastically orang masuk ke rumah sakit yang strategi ketiga ini. Strategi ketiga ini saya lihat the number of cath lab increase dari 44 cities to 190 in the last 2.5 years. Gitu ya. Jadi 2022 saya selesai COVID, 44 cities punya cath lab. Sekarang yang sudah jalan 119. Ya. Yang saya minta ke harapan kita, saya mau cath lab ini fully implemented and running, ya. Running yang penting di 514 kabupaten kota by 2027. Runningnya tuh dia bisa lakukan angiografi dan angioplasti dengan stent, itu aja. I only ask 2 things, ya. Jalanin cath lab, implementasi 514 kabupaten kota, dan all of them harus bisa angiografi dan PCR. Situ aja dulu. Itu aja dulu. Sekarang yang sudah bisa naik dari 44 ke 119. Terima kasih. Tapi beberapa PR harapan kita. Saya ada data bahwa sekitar 40 cath lab itu belum beroperasi pada udah datang. Segala macam problem. Problemnya banyak di Bapeten belum approve, kemudian BPJS belum approve. Pak Iwan harus duduk dengan Pak Kunta memastikan semua approval birokrasi red tape itu di bypass cepat. Ya, 3 bulan ke depan saya mau lihat 40-an cath lab yang sudah terpasang itu, yang ada udah 3 tahun nggak keluar izinnya, 2 tahun nggak keluar. That is very ridiculous in my view. Kalau perlu aku minta tolong Pak Tito juga untuk tekan-tekan itu. Kalau BPJS nggak approve, jangan bayar itu ya BPJS-nya, UHC-nya. Biar dia approve. Kalau Bapeten nggak approve, panggil ke sini, kita panggil kepala Bapeten. Ya. Tapi nggak bisa 40 ini udah dipasang, warrantinya udah habis belum dia approve. Ada 5 yang warrantinya udah habis. Itu pemerintah daerah beli sendiri Pak Arya Biamar ya. Ya, mereka beli sendiri, nggak tahu mungkin harganya juga 2 kali lipat lebih mahal, dia beli sendiri, kemudian dia hobinya beli. Tapi bukan pasang. Yang saya lihat yang paling banyak yang masalah ada yang dibeli oleh Pemda lewat DAK fisik. Ya. Begini aja Menkesnya udah dibilang proyek mercusuar, apalagi gini kejadiannya gitu kan. Jadi saya ingin memastikan bahwa those 40 cath labs itu the approval from Bapeten sama BPJS in the next 3 months harus keluar. Ya. Untuk bisa segera dijalankan. Karena kita akan deploy 50, 100 lagi sampai sana. Nah, untuk deployment ini kita ngelihat dari sisi mesinnya, karena anggaran sudah ada udah pasti jalan. The problem adalah orang-orangnya Pak Iwan. Ini kita sudah hitung kekurangannya banyak. Itu sebabnya sekarang thanks to harapan kita very open sama Ibu Ade ini dari konsil yang sudah mau mengirim serang berapa ya, 100 lebih masalah 100 lebih dokter SPJP ke luar negeri, ke Cina, Korea Selatan, Jepang untuk belajar fellowship intervention. Dan saya berharap tahun ini batch pertama sudah kembali. Dan kita sudah dengar perbaikannya apa yang perlu kita lakukan, apakah case-nya cukup apa enggak. Tahun depan saya harapkan itu kembali lagi. Ya, supaya kita bisa ngejar minimal, maksud saya satu rumah sakit ada cath lab, satu yang bisa intervensi, which is doesn't make sense. Karena dokter kan butuh libur, butuh belajar. Ya. Minimal harusnya setiap 514 kabupaten kota ada 2 orang yang bisa lakukan PCI, intervensi. Dan itu saya rasa sampai 2027 minimal 1 aja dulu. Ya, sehingga alatnya bisa kepake. Nanti mudah-mudahan 2 tahun, 3 tahun ke depan kita bisa lengkapi masing-masing punyanya 2. Dan buat teman-teman, kita gapsnya tuh 350-400 nih untuk 1. Kalau untuk 2 gapnya mungkin bisa jadi 1000 SPJP intervensi itu. Dan bayangkan berapa banyak kita sekolahnya, teman-teman tahu sendiri. Mungkin berapa, 25, 30, 40 kapasitinya. Masa kita butuh 40 years? Mati semua orang-orang itu 350. Itu sebabnya kenapa saya minta kolegium more agresif untuk memperbanyak kesempatan ini. Kalau seatnya nggak ada dalam negeri, kita kirim luar negeri, kita yang bayar, agar pengisian tenaga intervensi ini bisa lakukan. Untuk ini aja 2, angiografi sama angioplasti with stent. Nah, tugas yang ketiga yang lebih susah, dan ini saya mau ada di 514 kabupaten kota by 2027. Ya, strategi nomor 3. Strategi nomor 4, saya mau ada kapasitas untuk bedah jantung terbuka itu diberesin di seluruh provinsi. Saya juga terima kasih, saya lupa tuh angkanya naik dari berapa, sehingga saya dulu waktu saya masuk 2022 tuh masih 17 apa 15, sekarang udah 29. Ada 5 lagi yang belum tuh. Saya ingat Gorontalo, Maluku Utara, aku lupa Bengkulu ya kalau nggak salah ya. Ada Papua. Itu harus bisa cepat diselesaikan kalau bisa tahun depan. 34 provinsi bisa lakukan bedah jantung terbuka, 2 aja yang saya minta. Valve replacement and repair, karena ini paling banyak kasusnya. Kemudian bypass, 2 aja. Ya, jadi tugasnya harapan kita memastikan by 2026 gitu ya, 34 provinces bisa melakukan bedah jantung terbuka untuk 2 hal tersebut. Valve repair and replace sama juga untuk bypass. Kan itu kejadian yang paling banyak. Nah, saya lihat terima kasih sekali ke harapan kita karena ini hanya 34 provinsi, alat-alatnya juga lebih relatif tidak semahal yang cath lab. Yang penting adalah dokter-dokternya dan perawat-perawatnya dan perfusionistnya dan lain-lainnya gitu ya. Ini mesti dipastikan bahwa tenaganya juga harapan kita beresin. Gunakan rumah sakit lain sebagai pengampu agar tempat latih buat nursesnya, karena ini kan khusus, tempat latih buat perfusionisnya, itu semua disiapkan. Tapi saya lihat tracknya bagus, jadi saya congratulate harapan kita yang bedah ini tuh udah deket, bisa lebih dekat dari 2027, tapi yang cath lab itu masih agak ketinggalan. Nah itu nilainya 6 buat Pak Iwan tuh, kalau ini selesai. Ya. Kalau mau nilai 7, saya minta untuk yang sudah punya cath lab bisa lakukan angiografi sama PCI, harapan kita harus naikkan nambah. Feeling saya, buat saya yang penting harus bisa aritmia. Ada apa tuh? Pakai radio frekuensi ablasi atau rubahlah pakai yang lebih baru, pulse frequency ablations. Lengkapin. Karena aritmia ini ada masalah. Jadi semua yang punya cath lab, kalau Pak ini pengen naik nilainya jadi 6 jadi 7 gitu nanti 2027, itu harus bisa handle ablasi untuk aritmia. Syukur-syukur kalau bisa buat pediatrik. Saya nggak ngerti tuh ASD apa VSD closure yang bisa pakai itu, lakukan juga. Ya karena pediatrik ini meninggal bayi kita 6 ribuan, 7 ribuan karena tidak tertangani. Ya jadi sesudah ini selesai, saya minta tahap keduanya, harapan kita harus bisa lakukan pediatric use of cath labs, mungkin ASD atau VSD closure, sama juga aritmia, ablasi. Ya, syukur-syukur pakai pulse, karena saya dengar yang pulse frekuensi ini jauh lebih nyaman, lebih ringan dampaknya dibandingkan kalau kita pakai radio frekuensi ablations. Ya, jadi ini harus bisa dilakukan juga karena alatnya udah ada, tinggal ditambah generatornya, ujungnya tuh diganti alatnya ya supaya bisa lakukan. Nah, untuk yang rumah sakit di provinsi, ini kalau mau naiknya nilai 7 itu kayak yang cath lab, yang kabupaten kota. Kalau yang provinsi, saya mau juga bisa ditambah operasi pediatrik. Jadi bedah jantungnya bukan hanya valve repair sama valve replace, bukan hanya bypass, ditambah lagi pediatrik satu kali lagi. Ya. Apa tetralogy of Fallot atau yang lain-lainnya itu masukin ke situ. Ya. Saya nggak minta yang Fontan, Norwood yang susah-susah. Saya minta yang itu bisa. Ya, itu dulu bisa dilakukan. Jadi itu nilainya 7 buat harapan kita. Tapi 6 dulu dipenuhin ya. 6 dulu dipenuhin adalah 514 kabupaten kota. Cath lab-nya jalan, izin Bapeten-nya keluar, izin BPJS keluar, bisa melakukan rutin setiap bulan, nggak hanya pada saat peresmian untuk angiografi sama angioplasi pakai stent. Di rumah sakitnya bisa lakukan operasi bedah, approval BPJS-nya keluar, alat-alatnya lengkap, dokternya lengkap untuk melakukan valve replacement repair plus bypass. Dan tiap kali jalan, nggak hanya peresmian oleh Menkesnya. Nah, habis itu nanti masuk tahap 2. Tahap 2-nya adalah cath lab-nya mesti ditambah untuk ablasi. Ya, kemudian bedah jantung terbukanya saya mau nambah untuk yang pediatrik. Ya. Nah, kalau mau dapat nilai 8, gitu kan, mau dapat nilai 8. Ya dilebihin dari itu. Lebihin dari itu lah. Cath lab itu sekarang bisa TAVI, bisa. Kita lagi ngomong nih, gara-gara kemarin ngeresmiin rumah sakit Emirates. Valve itu kan gak usah dibelah sekarang, tinggal masukin pakai cath lab bisa, cuma alatnya mahal kan. Kita udah ngomong di Cina ada, kita lagi coba, bisa nggak kita coba di rumah sakit Emirates kita, karena mau dibayarin sama Raja Dubai. Saya bilang bayar apa? Oh bayarin itulah, beliin apa tuh TAVI yang mahal-mahal gitu, biar bisa praktek. Ya. Kemudian segala macam, misal pasang apa tuh, aritmia kan bisa pasang pacemaker, bisa pasang apa ICD gitu kan, lebih banyak. Nah itu dilakukan pakai cath lab. Ya, itu yang kalau mau nilainya 8. Jadi cath lab itu dipakai untuk advance lagi. Pakai untuk ICD implantation, pacemaker implantation, maupun juga untuk itu tadi tuh apa yang valve tapi di implannya pakai cath labs. Ya. Kemudian yang bedah jantung terbuka sama yaitu teknik-teknik yang orang Arab dulu lakukan, bental misalnya, bental procedures dilakukan di Adam Malik. That is the first bental procedures di luar Jawa. Nah itu bisa dilakukan. Ya kalau bisa ditambah tuh. Provinsi-provinsi bisa melakukan bental procedures. Kemudian prosedur-prosedur pediatrik yang susah-susah tuh, Norwood, Fontan itu bisa dilakukan di rumah sakit provinsi juga. Sehingga dinaikkan lagi. 8 tuh buat harapan kita. Ya. Nah kalau mau 9, itu kan aku kesal kalau mau 9. Harapan kita itu mesti masuk ke leading edge procedures. Contoh, kemarin saya ke Surabaya, saya lihat mereka melakukan minimal invasive cardiac surgery untuk valve repair. Jadi instead dibelah, dia masukin laparoskopi itu. Nah kalau harapan kita bisa ngatur semua rumah sakit Kemenkes aja dulu. Aku nggak usah provinsi. Semua rumah sakit Kemenkes bisa melakukan mix minimal invasive cardiac surgery. Itu nilainya 9. Kalau itu bisa, nanti harapan kita aku kasih robot yang paling mahal agar bisa melakukan ini, gitu. Tapi mesti buktiin bahwa beberapa rumah sakit Kemenkes mesti diajarin laparoskopi dulu. Gimana bisa pakai robot kalau laparoskopi aja nggak bisa, gitu kan? Jadi harus ajarin tuh, mix minimal invasive cardiac surgery, ganti valve dulu aja gampang, ganti valve yang gampang. Minimal rumah sakit Kemenkes, Hasan Sadikin, Karyadi, Sarjito, M. Husin, Murah, Wahidin tuh harus bisa mix, ganti valve. Yang gede-gede, misalnya Murah kan jago jantungnya tuh, Sarjito jago, itu harus bisa mix buat bypass. Sekarang mix bypass aku tanya yang bisa cuma harapan kita seorang. Gitu kan? Nggak bagus tuh, kalau ilmu nggak dibagi-bagi nggak bagus. Ya, jadi kalau harapan kita mesti ngajarin siapa yang jago, RCM. Misalnya si M. Husin aku nggak tahu, Murah kan bagus. Ini bagus. Dia harus bisa melakukan minimal invasive tapi untuk bypass. Nah itu nilainya 9. Dan harapan kita juga harus mulai melakukan research untuk teknologi baru, misalnya pasang LVAD. Aku nggak tahu udah pasang belum LVAD, udah bisa belum harapan kita pasang LVAD. Karena transplant janji-janji doang gitu kan, janji doang, Pak udah transplant nggak nemuin jantung, nggak putus, meninggal, segala macam alasan keluar. Dia janji loh sama saya nggak, dia gagal janji yang memenuhi harapan kita. Tapi kalau bisa pasang LVAD aja dulu. Udah ada. Berapa? 1. Nah, gitu, suka tuh. Bagus tuh. Itu udah 8,7 gitu kalau 1 kan. Udah dekat. Ya. Kalau bisa jangan pasang LVAD 1. Gitu, gimana dokternya pintar ya? Pasangnya lebih. Ya, kalau mahal cari produk Cina aja. Banyak kok produk-produk Cina yang bisa lakukan LVAD. Sehingga kalau kita punya structural heart problem, nggak usah ditransplant dulu, ya, tapi lakukan dengan LVAD. Saya juga minta harapan kita, udah saya kerjasamakan sama Osaka from Japan, karena Nobel Prize winnernya untuk health itu datang dari Osaka, untuk lakukan induced pluripotent stem cell. Di mana kita mau coba pasang patch untuk restructure heart failure, itu bisa dipasang. Katanya nanti bisa meregenerate lagi pembuluh darah sama jaringannya, yang aku dengar. Dan karena ini dilakukan oleh ilmuwan Jepang, Nobel Prize winner di sana, jadi saya agak yakin. Jadi harapan kita harus go beyond to the limit of the new technological procedures. Jadi saya bilang LVAD-nya harus, transplant jantungnya aku masih tunggu, dijanji-janjiin terus sama harapan kita, sampai sekarang belum terjadi gitu ya. Jadi kalau mau 9 itu LVAD, jantung, sama coba yang induced pluripotent stem cell itu dicoba clinical trialnya dilakukan di Indonesia. Sehingga a new structural problem in heart, teknologi barunya itu ada. Di sini juga ada dewas-dewas harapan kita, di sini juga ada senior-senior harapan kita. Jadi tolong yang maksa-maksa jangan main case-nya biasa maksa gini supaya mereka terpacu. Dan saya senang harapan kita kalau di challenge nggak marah gitu kan, ada yang di challenge marah gitu ke saya kan, ini kalau di challenge dia nggak marah tapi dia lakukan. Nah, itu attitude yang sangat baik dari harapan kita, sehingga tujuan kita memberikan layanan jantung yang paripurna ke seluruh Indonesia, bisa diakses oleh siapapun dia, baik dia tinggal di kota, di desa, di pulau mana itu bisa terjangkau dengan merata. Sekali lagi saya ucapkan thank you harapan kita, and thank you for our guests. I'm sorry I talk in Indonesian some of the time because there are majority of our people here, although they understand English, because the heart surgeon, heart nurses are the smartest compared with the others gitu kan. Specialty ya, tapi hopefully you understand that I need to make sure that my message to them is well understood. Otherwise they read only from WhatsApp group about what the Minister of Health want to do, and when they read the WhatsApp group, they say, oh, this Minister of Health is a ridiculous person, doesn't understand health, don't have any heart, to support the people. Actually, I'm not. My objective is only one, to save people's life, dan saya harapkan kita can reduce fatality coming from cardiovascular disease. Terima kasih sekali lagi, selamat buat harapan kita di Reksia dan teman-teman penyakit jantung, dan let's save people's life. Terima kasih, wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Budi Gunadi Sadikin, for the valuable message. We kindly request Mr. Budi Sadikin to remain on stage, as we will now proceed with the opening ceremony of the Indonesia International Cardiovascular Summit 2025.
And for this, we also invite Dr. Iwan Dakota as President of Director of Harapan Kita to come to the forward. Dr. Bima Arya Sugiarto, Deputy Minister of Home Affairs of Republic of Indonesia, Directors of Clinical Services, Ministry of Health of Republic of Indonesia, represented by Director General of Advanced Healthcare Service, Mr. Obrin Parulian, we invite Ms. Yuli Varianti, Director General of Health Human Resource Development. We invite the Chairman of Indonesian Health Council, Dr. Arianti Anaya. We invite Prof. Asnawi Abdullah, the Head of the Health Department of Policy Agency, Ministry of Health. Prof. Kinya Otsu, the President's National Cerebral and Cardiovascular Center, Japan. Mr. Takeshi Ohashi, Vice Chairman of Tokusukai Medical Group. Mr. Futoshi Yamanaka, Shonan Kamamura General Hospital. Mr. Shigeru Saito, Shonan Kamamura General Hospital. Mr. Motoaki Kai, Shonan Kamamura General Hospital. Mr. Shun Sawada, Shonan Komamura General Hospital, Miss Erita Nemura, Sapporo Tokusukai Hospital, Miss Sayuri Toma, Chubu Tokusukai Hospital, Mr. Kunta Wibawa, Dr. Muhadi, the Director of Medical and Nursing Services, harapan kita. Dr. Diki Armin Hanafi, the Director of Human Resources, Education and Research of harapan kita. Mr. Tri Hartono Rianto, the Director of Finance and State-Owned Assets of harapan kita. Dr. Maya Marinda Monten, the Director of Service Planning and Strategic Development of harapan kita. And Dr. Harudin, the Director of Operational Services, National Cardiovascular Center harapan kita.
Honorable guests, the compact instruments will now be distributed to the VIPs for the opening ceremony procession.
Kepada Dr. Ademilian Ambari, diharapkan kepada yang terhormat, para hadirin, kami mohon kesediaannya untuk memukul kompang yang telah diberikan setelah hitungan ketiga sebagai simbol pembukaan acara ini. Distinguished guests, we kindly ask for your honor to strike the kompang after the count of 3 as a symbolic gesture to the mark opening of this event.
Dari tanah Melayu Nusantara, lahir adat dan adab. Dari nadi bangsa, lahir ilmu dan pengabdian. Dengan bersatunya langkah para pemimpin bangsa, nadi negeri kini hidup.
Together, let us inaugurate the 3rd Indonesia International Cardiovascular Summit 2025. On my count, 3, 2, 1.
Thank you very much to our VIP guests for officially opening the Indonesia International Cardiovascular Summit 2025. We kindly invite all VIP guests to remain on stage and move forward to the center of the stage. We will proceed with a group photo session as part of the official documentation for the opening of the Indonesia International Cardiovascular Summit 2025.
Once again, we extend our sincere gratitude to all VIP guests for your presence and support at today's opening ceremony. We kindly request Mr. Budi Gunadi and Mr. Iwan Dakota to remain on stage as we proceed to the book launching sessions. And to our other distinguished VIP guests, we respectfully invite you to return to your seat. Thank you for your time and participation. Hadirin yang kami hormati, perjalanan ini bukan hanya tentang inovasi, tapi juga tentang warisan panjang yang dijalani dengan konsistensi dan pengabdian. Mari kita rayakan 4 dekade dedikasi RS Jantung dan Pembuluh Darah Harapan Kita.
We also invite distinguished contributors of the book to join us at the front of the stage, Mrs. Rini Sukaman, Dr. Hananto Andriantoro, Dr. Irma Lita, Dr. Tarmizi Hakim, Dr. Nur Haryono, Dr. Ana Ulfa Rahayu, and Dr. Liz Dina to come to the stage.
Empat 40 tahun perjalanan adalah 40 tahun cerita manusia. Dan hari ini kisah inspiratif itu kami abadikan dalam sebuah buku.
We respectfully invite Mr. Budi Gunadi Sadikin and Dr. Iwan Dakota to step forward for the official book launching ceremony.
Now we kindly request Mr. Budi Gunadi Sadikin to lift the book as the symbolic launch of this special publication.
Once again, we invite Mr. Budi Gunadi Sadikin and Dr. Iwan Dakota to step forward for the official book launching ceremony.
Dengan ini, buku Melayani Nusantara Menggapai Dunia yang merupakan perjalanan RS Jantung dan Pembuluh Darah Harapan Kita selama 40 tahun dan visi ke depan resmi diluncurkan.
Thank you very much to all contributors and our distinguished guests for joining us on stage. We kindly invite all VIPs to return to their seats and for the Minister of Health to leave the venue. Thank you so much.
We invite all contributors and our distinguished guests on the stage together for a group photo.
Now we invite Dr. Bima Arya Sugiarto to present bouquet of flowers as a token of appreciation to our book contributors who are with us on stage today.
Mengundang kepada Dr. Iwanda Kota dan Bapak Bima Arya untuk ke tengah untuk berfoto bersama.
Once again, thank you very much to our all contributors and our distinguished guests for joining us on stage. We kindly invite all VIPs to return to their seats. Once again, our gratitude for the Deputy Minister of Home Affairs, Dr. Bima Arya Sugiarto, for your presence in our event this morning.
Ladies and gentlemen, please remain seated as we will now present the historical book video showcasing the remarkable journey and legacy behind these publications. We invite all guests to direct your attention to the screen. And now, here is the historical book video.
Ladies and gentlemen, thank you for watching. Now, please enjoy our next performance, a special traditional Malay dance accompanied by a live Malay band performance.
terkesan pala, lipatlah tangan, sanggul di padu, kita berdendang bersukaria, lagulah Zapin, aduhai sayang rentang Melayu. Raja Dilan bersemayam di bukit batu. Ahai hati siapa, ahai kau terpaut, mendengar lagu Zapin Melayu. Laksamana Raja Dilan bersemayam di bukit batu. Ahai hati siapa, ahai tak terpaut, mendengar lagu Zapin Melayu.
A big applause to our dancers and our very enthusiastic audience. Thank you once again to our dancers and musicians for that wonderful and fun traditional Malay performance. Ladies and gentlemen, we will now continue with our scientific agenda. Our next program is the live session, Coronary Intervention, with a session titled CTO-PCI in the New Era, Integrating Imaging Strategy and Device Innovation.
This session will be moderated by Dr. Doni Firman, PhD, and will feature leading expert presenting advanced imaging approach, procedural innovations, and collaborative live demonstration from multiple centers. With that, Dr. Doni Firman, the stage is yours.
Kertas ini, urutan acara dan udah ya. Kertas ini nggak ada, kertas satu ininya nggak ada. Oke, nggak apa-apa. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. And then welcome to the live session 2. This is, I think it's a very special session because we are going to have a live transmission from 3 centers all over Indonesia. Main topic will be coronary intervention. So before that, I would like to invite our faculties here. My name is Doni Firman. I'm working in the Harapan Kita National Heart Center. So I would like to invite our first panelist, Dr. Daf Juzar from Harapan Kita. Please, Dr. Daf, come step forward. And then Dr. Amir Aziz Al-Katiri from Harapan Kita, now the head of the CAT lab. And our junior, Dr. Hana Soraya from Harapan Kita as well. And then also I would like to invite our guest, our teacher actually, Professor Shigeru Saito. Please come forward, Dr. Saito. Dr. Saito is senior interventionist from Japan and regularly coming to our center since 15 years ago. Our teacher. And then coming to Harapan Kita, teaching us, I think, more than 5 times. He's really renowned for the transradial coronary intervention and chronic total occlusion all over the world. And then I would like also to invite Dr. Shun Sawada from Shonan Kamakura, Japan, and Dr. Moto Akikai from Shonan Kamakura, Japan as well. All right, so let's start our session today. So I would like to transmit the first live case from hospital RSUD Dr. Haji Yusuf SK from Tarakan, Kalimantan Utara, North Kalimantan. So if you have any already, so please, the committee, can we have a transmission from Kalimantan, please? Is it ready for Kalimantan? Okay, there you go. Hello, Tarakan, can you hear me?
Yes, I can hear you, sir.
Okay, thank you very much. So, good afternoon, selamat siang, assalamualaikum. So, all right. So now we are in the Pullman Hotel Convention Center and transmitting your from Yusuf SK Tarakan Hospital in Kaltara. With me today, we have some faculties, from distinguished faculties, Dr. Dafsa, and then Dr. Amir Aziz, Dr. Hana, and then Professor Saito, Dr. Shun Sawada, and Dr. Moto Akiakai. So, can you introduce yourself and team, maybe Dr. Morlim?
Okay, thank you, sir. Good day, sir. From North Borneo, Tarakan. We feel very excited, sir, because this is the first time, the first experience, and we feel very honored, sir, for your invitation for this live case in ICCS, the third ICCS in Pullman Hotel, sir. And before we, behalf of our hospital, we would like to say thank you for Ministry of Health in Indonesia and Director of Harapan Kita, Dr. Hananto, and especially we would like to thank you for Dr. Hananto, because he made our dreams come true, sir. Because for almost 5 years, Harapan Kita already helped us and assist us to improve and develop our cardiovascular services, especially in cardiology intervention, sir. So I think it's a best encouragement for us, sir. Thank you, sir. And I would like to, of course, we like to say thank you for Boston Technology for support us to make this transmission a very good run, Doctor. And I would like to introduce myself, Doctor. I'm Morlim Limbong, Doctor. And here we have a great team. My scrub nurse, Mr. Otniel, and Yuanita, and we have radiographer, Mr. Wawan, and circular is Nurlinda. And of course, I would like to say to thank you because I have a special guest, Mr. Dr. Arwin Mangkwanom, who accompany me here to make this live case run through very well, Doctor. And of course, we have Mr. Simon from Harapan Kita. Simon. Sir, okay.
All right, okay. Thank you, thank you. So we have very clear pictures and also a very clear sound. So can you, let's move to your case. Can you introduce,
Yes,
your case maybe? Is there any case introduction so everybody knows about your case?
Yes, if we have a presentation there, we have a 48 years old patient male, sir. He is asymptomatic actually, but from routine medical checkup, we found suspicious ischemia, ischemia in the stress test, sir. And then we performed several examinations, and we found there's a good LV and RV function. And the patient performed MST coronary, and we found there's a CAD2 vessel disease, Doctor, moderate lesion in LAD and tubular stenosis in tight lesion in the RCA, Doctor, 80%, Doctor. So this is because there's a 2VD lesion in MSCT. Then we performed 4 months ago coroangiogram, Doctor, and we can see here, we can appreciate there's a moderate lesion in the LAD, about 50 or 60%, but there's a slow flow to distal of LAD, Doctor. And then we move to the circumflexion. I think the circumflexion appreciate very well vessel. Maybe the next slide. And this is the circumflexion. I think the circumflexion good vessel. And then in the RCA, there's a tight lesion, maybe focal lesion in the proximal of the RCA, about 90% in the RCA, Doctor.
Can we have the RCA picture, please? Now we have left. Okay, there you go. Okay, okay, let's play.
RCA, Doctor, the tight lesion in the proximal, say, sir.
All right, okay.
Yeah, since we already done the FFR, can you please show
Okay,
the FFR result?
Okay, before that, maybe I will summarize a little bit because we have we have a gentleman with a two-vessel disease, moderate lesion in LAD, and also look like a very tight lesion in the RCA. Am I right?
Yes, sir.
Okay, so we have a distinguished panelist here. We have, maybe I will ask maybe Dr. Dafsah, maybe, what do you think about that? So, because not of our attendance is interventional cardiologist, so I think, let's make it a little bit easier to understand. Okay, please, Dr. Dafsah.
Thank you, Dr. Doni, and hi, Dr. Lembong. And I think you brought up an interesting case. First, this is asymptomatic, and you find that this from stress test there is a suspicion, and then the CT show there is a moderate lesion, and then you confirm it with the angiogram. So the question is, which one is the culprit lesion? You see the RCA, I think is 99%. The LAD, it looks moderate, but the flow is, can you see, it's not TIMI3 flow. That could be non-coaxial injection, or it's actually significant disease or microvascular obstruction. But I think from the caudal view, you see the ostial also seems very tight. So I guess I would agree that you, in this case, to do a physiology study, or I think it would be justified as well to make sure that the osteal LAD is actually very severe from intravascular imaging and then proceed for intervention.
Thank you, Dr. Dafsa. So we have moderate lesion in LAD. So maybe our teacher, Professor Saito, in LAD, you prefer to choose a functional study, or you directly go for IFUS maybe?
Okay, I think for this particular patient, the problem is which regions will be the most significant. And usually, if the patient has several regions in the branches, we check by using FFR whether which regions are most significant. And for this particular patient, of course, we can take FFR examination. However, for this patient, the right coronary artery territory is quite not big, and the LAD territory is quite huge, and also the blood flow is distinguished. So for this particular patient, I want to start from LAD FFR and then confirm the ischemia and then go to the stenting. That is my strategy.
Thank you, Professor Saito. So, Dr. Morlim and Dr. Arwin, can you describe what have you, proceed, what have you done?
Okay, sir. We already we decided first. We decided to do a physiologic examination in the LAD using IFFR wire, and we appreciate here from IFFR we can found the PD per PA is about 0.9, sir, and then we confirm with twice injection of adenosine 100 and 200, and we appreciate a good result with PD per PA is about 0.9 also, doctor. So I think it's not significant lesion, but maybe I agree with Dr. Dafsa, maybe it's a microvascular disease, doctor, because of the slow flow, doctor. So maybe we have to defer a PCI in LAD, doctor.
All right.
Maybe
so
another.
Sure. Okay. Thank you very much. So the conclusion that the LAD not need to be treated. So you're gonna move to the RCA or already moved to RCA?
Yes, doctor. We already perform PCI in RCA, and we perform IFUS from the RCA, and we can appreciate here. Please move. Play. This is the IFUS, doctor. We can see here and appreciate there is a lesion, fibrous lesion in proximal of the RCA, with the length approximately maybe 50 millimeter the length, and approximately the MLA about 4 millimeter, the same between the proximal and the distal of the RCA, doctor.
So the tightest one, the MLA is about
2 point.
Oh, 2 point.
The green one.
Okay.
Yeah, 2.2.
Oh, 2.2. Okay, we have fibrotic. Yes. So may I ask Dr. Sawada maybe? So in the particular IFUS like this, what is your strategy, Dr. Sawada?
Play dari awal.
Thank you. I think the region of RCA is fibrous plaque main region, and so maybe a balloon inflation and stent deploy is finished.
Okay. Okay. Thank you. So balloon inflation. So Dr. Kai, maybe. So what kind of a balloon you suggest? Do you need a normal balloon or NC balloon or scoring or?
Thank you, Chairman. I choose semi-compliant balloon. So and because the region is almost soft plaque mainly. So I choose semi-compliant balloon, and after that, deploy the stent.
All right, so this is, I think, the classic approachment. I mean, you're doing the normal balloon and then stand. So what did you do, Dr. Morlim and Dr. Arvin?
Okay, sir. After we appreciate the from IFUS, then we proceed to PCI, doctor, and we decided to pre-dilatation the proximal RCA with balloon Scoreflex NC 2.5, doctor, 20 ADM, and then we.
Can we have an angiography picture, please? Angio. Okay.
This doctor.
Okay.
The 2.5 Scoreflex, and this is another inflation here, and looks like the lesion is starting from the ostial, and we currently at this point, Dr. Doni.
All right. So did you do IFUS after dilatation or not?
Not yet.
Not yet.
Not yet.
Oh,
you
not
want
yet.
to perform the IFUS run?
But what about this, Dr. Amir? Do you need another IFUS study, or you directly go for the stent?
Yes, thank you, Dr. Doni. First of all, is when we have a IFUS pullback, the first thing that we have to do after
the balloon.
Yes, after the IFUS is already in place, such as in the mid or distal RCA, is to disengage the guiding catheter. For this case, I think very important because we want to know whether the disease is extending to the ostial of the RCA. And the second thing is if this kind of, in this particular lesion in 41 years old, which is lipidic and also fibrous, after you do simple pre-dilatation, whether you use just semi-compliant or non-compliant is actually enough, you probably do not need to do IFUS again because you don't really need that kind of information because you can directly do the stenting. The third point is I want to make is if you have the disease up to the ostium of the RCA, I think it is very useful to have another wire in the aorta, which is a floating wire technique. I think this is a very simple technique to tackle the ostium, the RCA, to make sure that the stent is covering the ostium of the RCA if, let's say, the disease is extending to the ostium, the RCA.
Okay, thank you. Good points, Dr. Amir. But look like our colleagues in Kalimantan right now already did another IFUS. Okay, can you describe the IFUS?
The problem from the IFUS run, the IFUS is in backward, forward because of the guide catheter. So after we doing another floating wire to the aorta, I think it looks like the guiding is better for stabilization. And that's why from the first IFUS run, I cannot measure the precision length for the lesion because of this IFUS movement. So this is after we balloon with the 2.5 Scoreflex. Can you please run from the, run? Okay.
Okay, what size of balloon did you do, the pre-dilate?
2.5, Dr. Doni, Scoreflex. I intended to use bigger balloon, but the biggest balloon here for the Scoreflex is 2.5 because there is even the short, but the fibrotic is quite thick. So maybe this kind of lesion is ideal for scoring or maybe even warfarin for cutting balloon. But what do you think about this? Is the stop there. I think maybe at the 2 o'clock and the 4 o'clock there is already dissection for the fibrous plaque. I think, what do you think? It is time to us to put a stent. The size of the distal reference is about 4.4, and for the ostial is about 4.4. So
Okay.
we will put the 4O stand maybe around 18 or 20 millimeters.
Okay, so you put the stand from the very hostile RCA, is it?
Yeah, we plan to.
Okay, all right. Okay, please proceed because we have a limited time. So, okay.
Synergy for 20.
Sometimes put the stand in the ostial, sometimes is very tricky because we must very precise in terms of the location. Professor Saito, what is your tip and trick when you're doing ostial stenting?
Thank you, Chairman. Okay, there are several tricks or tips for ostial region stenting. So the fixation of the stent position is sometimes quite difficult because of the beating heart. And then we sometimes we put the one more wire in the aorta, and then we can identify the real ostium of that vessel. So that is some tricks.
All right, thank you, Professor Saito. I think that's what Dr. Morlim and Dr. Arwin doing. So you will already put another wires on the ostial?
Yeah, we already put
Floating wire, doctor.
a floating wire, and yet it's 0.6.
Okay,
gram.
so what is your projection? Angulation of your...
Now is LAO-cranial, but I think we need another maybe from spider,
Yes.
the confirmation of the ostial position.
Spider, please.
Okay.
No, I
yes,
think
yeah,
you
okay.
stay here first. We put a stand, and then we take
Yes.
another angio from the spider. Oh, sorry. We lost the... Okay.
Okay. Okay, it's okay. Just continue your work. It's happened every time. Yes, just relax. So I know the audience, not all cardiologists, and maybe not familiar with that. So this is the pictures of the angiography for the general doctor, maybe not cardiologist. So our target right now is the right coronary artery or RCA. So you know that we have 3 coronaries, 2 on the left and 1 on the right. So that our target right now is the RCA, the right. So our target is in very, very proximal. You can see there's some narrowing there. So there is some narrowing, some stenosis there. So the team from Tarakan want to dilate it and already dilated and want to put a stent in that area. So we do, the team already did not only angiography but also IFUS. IFUS is ultrasound, USG. But USG in coronary artery is really unique because it's very, very small catheter. I forgot the diameter, Dr. Duff, maybe you remember, Dr. Amir? I think 2 French or what? I mean, very, very small, so we can insert to the coronary artery, and then we can see the lesion, because each lesion has different scenario. If so many calcification, too many kapur, too many calcification, so it will be tough. So we will need more and more tools. But if the lesion is soft like this, maybe the need for the tools is not very high. So we just need 1 balloon, and then I think the team will insert the stent.
Dr. Doni, I just, yeah, can I comment?
Please, sure.
Yes. Yeah, I think for the safety reason, one of the important thing when you do the PCI of the RCA, especially involving the ostium or very proximal of RCA, is your eyes have to frequently see the hemodynamic. Of course, somebody else is doing it for you, or the nurse, but I think very important you see the hemodynamic, because most of the time the blood pressure go down or the heart rate is go down, bradycardia and other things that you may have to prevent for the first place. So, and the second thing, I think for ostium RCA stenting is the best view from the CT scan study was the LAO cranial. So we can really see the ostium of the RCA quite clearly. That's, I think, few points.
Okay, thank you. That is a very important message. So I think the balloon is already okay.
Yeah, we already implant the stand.
Okay, the hemodynamic okay, blood pressure okay.
Yeah, the hemodynamic is stable. Now I'm going to put another IFUS rod.
Yes, please do. So in terms of post dilatation of stent, so Dr. Hana, what will you expect after we put a stent? So what IFUS study that we expect?
Yeah, I think especially for RCA, because it is a quite large cerebral vessel, it is a dominant. So I think we will see the IFUS after the stenting. So we'll know if it's already well opposed and well expanded. I think we will see if there's any edge dissection of the stent, and also we want to see if it's the stent area is already exceeded, I think, more than 5.5 for the IFUS in this study, Dr. Doni.
Okay, okay, thank you. So we are waiting for the IFUS. So Dr. Kai, so what is your expectation of the MSA after, in RCA particularly? So is there any particular number that you expect regarding the MSA, minimal stent area?
MSA. So.
Votingnya dibiarin aja. Voting tolerances kita bisa dorong lagi.
I will check the IBUS, so no stent malposition and.
Yeah. Okay. Yeah. Let's wait for the eye first. Is there any comment from the other panelists, maybe?
Back.
Look like, okay. Can you do some flash so we can see clearer?
Oh, sorry. Yeah, okay.
Okay, there you go. Okay. Stand this is the stand for the audience not familiar. You know the white, not dot, yeah, white dot. Yeah, white dot here. It is the stand. Yeah. Kalau orang bilang ring, nah itu stand, coronary stand. Look like is good, well opposed. So we are waiting the ostial. So what do you think, Dr. Duff? Do you need any post dilatation, or you happy with that?
Play aja.
Yes, I think Dr. Hana already mentioned, I think the 5.5 only the minimum, but the bigger you get, the less of the incident of restenosis. So you would like to get as big as you can. As long as it's already well opposed, in this case, I think there is some area that you can actually still expand a little bit. But if you don't, I think this is good enough, and you would have a low risk of restenosis. And the other thing is probably the ostium. I think we can see is about 1 or 2 strata is in the aortoostial, in the aorta. So I think for future intervention, I think it's best to do some post dilatation in the ostium to flare the stent.
Okay.
Yeah, thank you, Dr. Duff. We are going to use a 4O NC emerge.
Okay. Can we have an angiography, Dr. Arwin?
Yeah, of course.
Yeah. Because we a little bit late of time, so we're gonna move to Ambon. So can you, okay.
Yeah.
Look like big enough, different compared to the initial angiography. So I think Yeah, you can proceed your procedure. Look like your final angio is good, and then we can move. So thank you very much for the team from Kalimantan, and big applause. We have a very nice demonstration of PCI in Kalimantan, and we can see very clear in Jakarta, Indonesia. So that's how to show how the PCI is benefit, and then to show that even in Kalimantan, very far, 3 hours from here by flight, Dr. Amir? 3 hours, yeah? 3 hours north. We can see that all the facility has been used very well. So look like, hopefully that people in North Kalimantan, have more and more a better healthcare, especially in cardiology intervention. So we hope we can move to Ambon. Ambon, I think, is 5 hours or 4 or 5 hours from Jakarta. Very beautiful, Ambon. Prof. Saito, you should go there sometime to go to Ambon.
Terletak di timur Indonesia, Provinsi Maluku, dengan keberagaman wilayah kepulauan, bersama Kementerian Kesehatan Republik Indonesia, menghadirkan Rumah Sakit Umum Pusat Dr. Johannes Lemina dalam pemenuhan kualitas layanan kesehatan yang prima untuk masyarakat di wilayah timur Indonesia. Berlokasi di Jalan Mr. CHR Soplanet, Negeri Rumah 3, Kecamatan Teluk Ambon, Kota Ambon. Berjarak 15 menit dari Bandara Patimura dan 10 menit dari pusat kota Ambon, menjadikan Rumah Sakit Umum Pusat Dr. Johannes Lemina semakin mudah untuk dijangkau oleh masyarakat. Dengan tujuan strategis dan misi yang kami miliki, kami terus bertransformasi dan berinovasi untuk memberikan layanan kesehatan prima bagi masyarakat. Sebagai rumah sakit vertikal pertama di wilayah timur Indonesia, kami hadir dengan layanan holistik dan terus bertransformasi dengan layanan unggulan. Layanan kanker terpadu, layanan jantung terpadu, layanan kemaritiman terpadu, layanan rawat jalan, instalasi gawat darurat, poliklinik, medical check-up. Dalam memberikan pelayanan kesehatan yang berkualitas dan bermutu kepada masyarakat, kami juga memiliki layanan pendukung, di antaranya kamar operasi berstandar internasional yang dilengkapi dengan sistem modular operating theater, instalasi radiologi, instalasi laboratorium, instalasi farmasi, instalasi gizi, layanan rehabilitasi medik, layanan hemodialisa, dan pemulasaran jenazah yang didukung oleh electronic medical record, layanan ambulans 24 jam, Central Sterile Supply Department, Binatu, Humas, dan call center. Ruang rawat inap meliputi ruang VVIP, ruang VIP, kelas 1, kelas 2, kelas 3, ruang perawatan intensif, ruang bersalin, didukung dengan sarana dan prasarana yang memadai meliputi area parkir yang luas, lobi dan ruang tunggu pasien yang nyaman, ruang pertemuan, pneumatic tube, gas medis sentral, musola, dan ATM center.
RSUP Dr. Johannes Lemina merupakan unit pelayanan vertikal di bawah Kementerian Kesehatan yang diresmikan oleh Presiden Republik Indonesia Bapak Insinyur Joko Widodo pada tanggal 25 Maret 2021 dan telah terakreditasi paripurna pada tahun 2022. Dilengkapi dengan fasilitas pelayanan yang canggih dan modern serta SDM yang berkualitas, andal, dan kompeten. RSUP Dr. Johannes Lemena sebagai rumah sakit pusat rujukan untuk wilayah Maluku, Maluku Utara, Papua, dan Papua Barat. Kami terus bertransformasi dalam memberikan pelayanan yang bermutu dan berkualitas kepada masyarakat. Kami siap menjadi mitra terpercaya untuk kesehatan Anda.
Kami terus berupaya meningkatkan mutu pelayanan karena kesehatan Anda adalah prioritas kami. RSUP Dr. Johannes Lemena, ramah santun untuk pelayanan.
Okay, can we directly communicate with our friend from Ambon? Can we have a picture? Transmission, go there. Okay, there you go. Okay. So, good afternoon, Assalamualaikum, selamat siang. Our friends in Lemena, Ambon, I can see your face, but even the mask look like you're smiling. So, hello, Dr. Isra. So, this is Doni. So, I'm here with distinguished faculties, Dr. Dafsah, Dr. Amir, Dr. Hana, and Professor Saito, and Dr. Sawada, and Dr. Kai. So, can you introduce your team and maybe your case, Dr. Isra?
Okay, hello Dr. Doni and to all the panelists. Can you hear my voice clearly?
Yes, please proceed.
All right, thank you. Now I will introduce my team. We are from RSUP Dr. Johannes Lemena, which is in Molucas of Ambon, Maluku, which is the eastest region in Indonesia. My name is Isra Tuasikal as the operator, and this is my colleague and also my senior, Dr. Irwan. And this is my scrub nurse, Nurse Nick, and also Surya, and also Wahyu as the radiographer, and Mas Firman in the monitor. So, Dr. Doni, that's all my team.
Okay, thank you. Can you introduce your case?
Okay, thank you very much, Dr. Doni. I'll start with my case. This is my case, is male, 57 years old, with the symptom of chest pain on heavy exercise, with the risk factor of diabetes mellitus type 2 and hypertension. And he didn't have any past history, and he has a good EGFR 80. And the ECG showed there is no STT changes, and also there is no T inverted. Then I sent him to treadmill test, and it showed a positive ischemic response. And I already give all the medication to him, but it still feel very painful. Then I send it to the cath lab. This is his ECG. Next slide, please. Yeah, as you can see, there is a normal ECG. There is no ischemic sign in here. Next slide, please. We start with the CAG. This is the CAG, Dr. Doni and the other. As you can see, there is a diffuse stenosis at the LAD part with the CTO in the proximal mid area. And the LCX is normal. Next. Yeah, this is from the spider and a bit from RCA. The RCA is already give the collateral to the LAD, but the problem is there is also some stenosis in the distal part of the RCA. I think it's about 70 or 80% though. The next. Yeah, this is 30-30 RAO cranial. I think it is a short CTO, and I think its GCTO score is about 2 because of blunted, and the length is almost 20 or maybe 1. That's my case, Dr. Doni. And next, next slide, please. So the plan is to do the double puncture, and we put Judkin Wright 3.56 French in the RCA, and also ABU 3.57 French in the LCA. And we do wire in the conus, LCX, and D1. Then our first choice of the wire is using any RSP Lancer 3 gram or Gaia next second. and with the backup of microcatheter Coaster SS. That's my case, Dr. Doni.
Okay, thank you. Very, very, very nice for our colleague from Japan. This is a transmission from Maluku, and then it's a relatively new hospital and new cardiologists as well. They are very young and very eager. I think the cath lab already started. I think less than 2 years, right, Dr. Amir? Yeah? Less than 2 years, but they are very, very, very patient to starting the procedure in Maluku. So again, that we have one lesion, but 100% occlusion. For the audience who's not familiar, there is 100% stenosis, sempit total. So there is no blood flow from the left side, but we have some collateral. Collateral means that some small artery coming from the other arteries to help, but it's not enough since the patient have chest pain. So they want to penetrate or make a way to deal with the 100% stenosis, 100% occlusion. This is not easy, especially for the starter. So we have our panelists, maybe from Dr. Sawada, maybe because you are very familiar with CTO. What is your strategy, Dr. Sawada? Dr. Sawada, sorry.
Thank you, Chairman. I have almost no CTO procedure, but if I project this lesion, first choice is antegrade, and retrograde contrast is good. So, okay, and this lesion maybe not maybe not calcification, and maybe plaque lesions. So we choose IVAS guided wiring. Yes. We maybe choose IVAS guided wiring, and maybe not passing a wire. So we maybe through retrograde approach.
Okay, good. Yeah, the thing in Ambon right now, as far as I know, they don't use IFOS yet. Yeah, hopefully in the next.
Yeah,
all right, that's okay. So look like it's not easy because look like the relatively blunt stump. I don't see any tapered one there. So maybe Dr. Amir, what your strategy in the blunt stump like this?
Yes, thank you, Dr. Doni. First of all, congratulations, Dr. Isra. I think new cath lab, new interventional cardiologist, and yet choosing a CTO for the first live case, which is, I have to congratulate you for this. The first point is one of the approach for CTO intervention, especially for this case, of course, you need a double injection. I think that is a must. Otherwise, you will miss the distal visualization. The second thing is you start with the microcatheter, of course. That is also a must. But before we proceed to the intermediate or stiff wire, I think very important to use workhorse wire with the backup of microcatheter. The function is to palpate the proximal cap. I think very important to have a palpation of the proximal cap by using your hand, because you need to have a tactile feedback. So you really show that this is a very hard or just intermediate or very soft. So sometime you can cross with the simple workhorse wire, or if you don't cross with that, in few minutes, you don't want to have a long time to use a workhorse wire, of course, just 2 or 3 minutes, you do intermediate wire. So my usual approach is usually just XT family with around 1 or 2 gram only before you start with a 3 or 4 gram tip load. So I think that is step by step because I think safety is also important. So I will try with soft wire first and then intermediate wire. Thank you.
Thank you, Dr. Amir. So we learned CTO from Professor Saito 15 years ago. So what do you think, Professor Saito? This is a very young operator, very young patient also.
Yes, this is a good case for the beginners to start CTO angioplasty. And this, I think this region has no classification at the region. But I want to confirm it by looking at the CT scan. I don't know the CT scan result.
Afraid not. We don't have CT scan yet.
And also, always I'm starting with a combination of microcatheter and maybe regular wire, and regular wire will be quickly changed to intermediate strength wire, and then quickly start change to the hard wires. And for these regions, I think visualization from the contralateral injection is not so much good. So maybe retrograde access may be difficult. So that means we have to rely on our antegrader approach first. Okay, anyway, you can start.
Thank you, Prof. Saito. So Dr. Isra and Dr. Irwan, can you describe what have you done for a few minutes? Dr. Isra, can you hear me? Hello? Can you hear me?
Oh, Dr. Doni.
Yeah. Please tell us what have you done? Hello?
I'm still, but if I'm right, you're asking of what did I do?
Yes. Please tell us. Oh, maybe you cannot hear me. Okay.
Okay, Dr. Doni, I will show my progress, Dr. Doni. Before, first one? Okay. This is our CTO, and this is the injection. As you can see, there is a blunt stump with the length about maybe 15. Then it's about GCTO 1 or 2. Next. This is from the another visual from the spider. I think there is no connection between them, and it's also stumpless. Then it's right, Dr. Amir. Next. Firstly, I'll try the tactile using workhorse wire, but I think the cap is really hard. Then I'll try drill a bit, but it cannot pass through. Then I think I will go with the higher one. The intermediate one is Any-Reach P 3 grams. Next. Yeah, it's keep deflecting everywhere. Then next. This is I thought we're going to the right place, but actually we're going to the septal one next. Okay, then I'll try to change the wire into Gaia next second, but it cannot pass through. Then I'll go with the Any-Reach P 6 gram. This is the Any-Reach P 6 gram. We went through the septal part of the LED. Next. It confirmed it's a septal part of the LED. Next, I'll try to advance the wire more distally. Next, then do a tip injection in the septal. Confirm. Next, Next. Yeah, I'll try to deflect my wire a bit because I kind of scared I cannot go pass through the LED. So next. Yeah, the passage is there, but my wire is too stiff. Then I'll change it into the XTA wire. Next. This is the XTA wire, and I think it glides smoothly into the LED. Next. Then something.
Congratulations.
Thank you, Doc. Next.
Great. So how many wires did you use?
Yeah, I think it's about 5, Doc.
Good.
It's
good.
5 wire, Doc.
Okay,
Yeah,
right.
but the
And
problem,
then
not yet finished there, Doc, because next, unfortunately, next, yeah, the lesion is calcified, Doc. It not open greatly. Then we escalate some balloon into 1.5, 2.5, and the last is using warfarin 2.5 high pressure, Doc. Next, last slide, please. Last slide. Yeah, the flow restored, but I think it not open fully, Doc. So what do you think, Dr. Doni and other panelists? Thank you.
oh, okay. Now you are in your last angio, is it?
Next, sorry. Oh,
Is
sorry.
it-
This is the warfarin. Yeah, this is
Oh,
my
okay.
last angel, Doc.
Okay, after warfarin,
After warfarin 2.5 high pressure, Doc.
high pressure. Is dilated well or not?
I think the proximal part is enough, Doc. Dilated well.
Yeah, the thing is, unfortunately, we don't have IFUS in Maluku right now. Hopefully, Menkes bisa dengar dan beli IFUS. so what do you think, Dr. Dafsa?
First of all, congratulations to you and your team. I think it's a very good case, and you actually overcome it very well. And I think the key point once you pass is to prepare the lesion, so you will have a long-term patency of your intervention. So since you don't have a IVUS, I think what size of cutting balloon did you use? I think I would go with try to go at least a quarter size smaller than 1:1, and then high pressure, and it has to dilate. If it doesn't dilate, I probably would just put a DCB and then send it to have intervention somewhere it can have a atherectomy device.
Okay, thank you. That's good suggestion. So yeah, in CTO like this, that like Professor Saito mentioned, he mentioned about CT pre-angio, which is very, very important to predict whether we need another tool, rotablator or not. So what size of your warfarin before that, Dr. Isra and Dr. Irwan? The size?
2.5.
2.5.
We inflated into the RBP. It's 2.7, Doc.
Okay, this is the warfarin?
Yes,
In
this
the-
is the warfarin. The length is only 6, Doc.
Okay, Professor Saito, do you have any suggestion since we don't have IFUS there?
Pardon, could you repeat?
Sorry. So they found a calcified lesion, and this point they already put 2.5 warfarin, but look like not very inflated.
What is giving warfarin for this patient? What do you mean? The patient has atrial fibrillation? No.
No. Warfarin is cutting balloon from Boston. Cutting balloon because they suspect some calcification there. So they have cutting balloon there, 2.5.
Cutting balloon?
Cutting balloon, yes. Do you suggest to have a bigger one, 3.0 maybe, or just is it enough? Looking by angio, Professor Saito?
I think from at this point, the after balloon inflation, there may be some, we can see some fragments of classification. So the first, I want to take the high pressure balloon after cutting balloon inflation and the high pressure balloon, and then check by using IBUS and then go to stent implantation.
Okay, Dr. Saito suggest to do the high pressure balloon, maybe bigger than that, maybe 3.0. What do you think, Dr. Dafsa?
Yeah, I think the vessel is at least 3.0, so it would be good to use a high pressure balloon to make sure that the vessel can actually dilate and then decide to stent it or not. If it's not, as I mentioned before, if it's not dilated, then I guess you should just put a DCB and then send it for to a center that have atherectomy device, so the patient can have a good patency for a long time.
Do you have a NC balloon 3.0?
Yeah, we have, Doc. We have NC balloon 3.0 and we also have the DCB, Doc, so we will try.
Okay, please please forward for the 3.0 NC.
All right, Doc. Heparin udah. Tambah heparin.
Yeah, the 3.0 balloon, and then look at at least 2 projection to make sure there is all well expanded.
4.000.
I think the other thing I like to mention from these 2 cases, as you realize that the patient are very young. One is 40 years old, and this one is, I think, this isn't 67, it's 57, also very young. I think from our registry, we see that patient that has a heart attack or infarct myocardium in our population is about a decade younger than the Western population or even the South Asian population. That's I think it's important point why this a lot of young. Of course, we have to find how can we reduce this incidence.
Yeah, that's a really nice point. So, Dr. Kai, what about in Japan? So, how many years, average patient coming to your cath lab? Maybe in ACS, acute coronary syndrome. So, how much the average age in Japan?
About 30 or 40% or PCI cases.
Yes, the average age, is there old, very old, or young?
About the average is 70.
70.
Yeah.
Okay. Go. In Japan, 70 years old, though they got heart attack. In Indonesia, 40 years old, already got heart attack. So we are much younger. Why? Because, I don't know, maybe Dr. Hana can explain why we have so many young population.
I think one of the reason is the lifestyle, also the very delicious food we have here, Dr. Doni, nasi padang.
We have, we love food, and then smoking also still high in Indonesia, and diabetes is increased, like our minister already told us, and then getting younger and younger. So that's why our population getting heart attack is relatively younger comparing to the other world. Even in Southeast Asia, Malaysia get older than us to get the first heart attack. Indonesia getting younger and younger. So that's something that we must say. Okay, it's already inflated.
12. Oh, it's open, Doc.
Okay, good. Like Dr. Rafsa mentioned, maybe you have another projection to make sure that it's already fully inflated.
Yeah. Probably epic caudal.
Yes, yeah, whatever. It's okay. Yeah, apicaudal and see what is still inflated or not. Make us some.
Yeah.
Okay, inflate again.
12.
6, 9, 10, 12.
Yeah.
Okay, good. I think it's very good.
I think
Maybe you
it's
have.
enough, Doc.
Okay. let's have some angiography to look. There's no dissection, hopefully.
Raw cranial 30-30.
Hi, during balloon inflation, we cannot see any pressure lines in the monitor. This is okay for in this catheter.
Okay. Do you have one pressure or two pressure? Is Irwan or Isra?
Actually, we have two pressure, doc, but the one of them is not show in the graphic, but it's only show in the number in the top left.
Okay. Okay.
The green
Exactly.
one.
Okay.
Sorry. One more time, Dr. Irwan. Yeah.
Okay.
No.
Look like it's inflated, and then for the audience who's not familiar, you can see the one before that is 100% total, and now is already got blood flow to the distal of the coronary artery. Okay, again, it look like it's okay. Maybe you do final angio and put a stent there.
Yes, doc. Okay, final angio. Sini. Okay.
Okay, so I think we agree he can put a stent there, right, Dr. Amir?
Yeah, I think I agree that we have shown that with two views, it is quite open. The other issue is whether you think that the diagonal is quite big, that you probably will need a protection, wire protection there. I don't know I don't know what's your plan, because there is probably some disease at the ostial proximal of the that big diagonal. I think you probably need the protection there and then put a stent.
More protection.
All right.
Okay, since we have a lecture here and also we must transmit again to Harapan Kita, so I'm afraid we not can follow you until the end. But anyway, we already see the beautiful result of the LAD, and then I would like to resume or stop our transmission to Ambon. Thank you very much, Dr. Isra and Dr. Molim. Very nice demonstration. And we are really proud of our youngsters getting, have a very nice job. Okay, salam dan sukses selalu untuk Lemena Ambon. Ya.
Terima kasih, dok.
Oke, bye-bye. Ya, sayonara.
Bye-bye. Dadah. Bye-bye.
Bye-bye. Okay, Gen Z. And now I would like to invite a lecture from Dr. I think it's Dr. Yamanaka, right? To talk about the imaging in physiology and CT/OPCI. Dr. Futoshi Yamanaka from Shonan Kamakura. Please, Dr. Yamanaka.
Okay, thank you, Chairperson. So, no laptop, no mouse computer, mouse. Okay.
Sorry, slide? We have Dr. Yamanaka slide, please? Okay, already there?
Okay.
Okay.
Okay. I'm Yamanaka from Shonan Kamakura General Hospital. Thank you so much for having me in this excellent meeting. Okay, next please. Okay, so first of all, I would like to introduce our hospital. Shonan Kamakura General Hospital was established in 1988. So now our hospital is one of the biggest hospital Tokushukai groups. So this hospital is located in Kamakura City, which is one of the old capital in Japan as well as Kyoto. Next, please. So Dr. Saito Dr. Saito has been leading our hospital for almost more than 35 years. Past 35 years, he started the Kamakura Live demonstration from 1991. He's now keep going. So next month, this year, Kamakura Live demonstration will be held. And furthermore, so he keep good relationship with Parapankita Hospital for more than 25 years. So we strongly hope to keep this relationship forever. Okay, so this is a long history friendship with Parapankita Hospital and Shonan Kamakura Hospital. So this is my colleague. This is my colleague worked in Parapankita Hospital 2011. So Dr. Sugitatsu here, and together with Professor Sunarie, so work together. 2012, Dr. Isman worked in Kamakura Hospital. This history made our friendship truly strong. So 2020, Dr. Amir worked in our hospitals. Today, so Dr. Amir is on the stage. And so I'm so much pleased to participate in same session together with my old friends. So he worked very hard and so really enjoyed the Japanese culture. So this is a traditional Japanese style restaurant, tempura. He's really enjoyed. So even though he worked Shonan Kamakura Hospital very short term, so he published a very nice paper. So this paper focus on TAVI procedure and mitral balloon valvuloplasty. So this is very nice paper. If you have some interest, please refer to. Okay, so back to today's topic. Today's topic is the CTO PCI. So first is we'd like to consider the advantage of imaging in CTO PCI. Second, so limitation of physiology wire-based FFR. So imaging should be needed in CTO PCI. So our answer is definitely yes. This is the algorithm of CTO regions. If first wire advanced in the whole lumen, guideline recommended IBUS guide image PCI. So this previous CTO session, so if first wire advanced into whole lumen, this algorithm could work. However, operator could really work well, so he successfully did. So today's I'd like to introduce the integrated IBUS guide wiring. This is a chip detection method. So if first wire advanced the whole lumen, we can manipulate the second wire, so on time visualized by IBUS. This is very unique technique. So I'd like to share the case of chip detection method. This is a CTO case of right coronary artery. As you can see, the mid RCA was occluded and some collateral from left coronary artery. Our initial plans are bilateral puncture. Both guided catheter size 7 French. So angiographically looks CTO entry like abrupt, and CTO length as more than 20. So first wire is guide wire is XTA supported by fine cross. So successfully wire advanced into distal RCA. However, so wire looks subintimal space. So IBUS, we tried the IBUS. IBUS showed wire is located subintimal, like this. So this is a advanced subintimal space. So I'd like to share the statistical image, this one. So this is a IBUS guide. So red line is the true lumen. However, so yellow line is the subintimal space. IBUS is located as the subintimal space. So we manipulate the second wire into the true lumen. So on time visualized by IBUS. As you can see, so IBUS in the subintimal space. So 7 o'clock, the second wire, so we manipulate into the true lumen like this. Wire into the true lumen like this. As you can see, okay? So we finally check so wire, so second wire in the distal portion, so inside the true lumen. Thus, so we did predilation like this. After predilation, we put 3 stents like this. This is the final angiography. This is so unique method, very effective, so safety. I think so this unique technique is a fundamental technique for CTO interventionalists. Okay, the next to move to second topics, limitation of physiology guided PCI wire-based FFR. And I'd like to emphasize the potential benefit of angio-based FFR. I know well, so some interventionalists doesn't like FFR guided PCI. However, so in the current guidelines, strongly recommended the FFR guided PCI. So previous live case, LAD FFR was 0.9, so operators so selected the defer strategy. So I totally agree with this previous operator. So defer strategy by FFR is so safe so for patient. However, so anytime FFR measurement is reliable, I don't think so. So I'd like to consider the FFR measurement pitfall in CTO PCI. This is a 70s-year male. So as you can see, so right coronary artery was occluded with heavily calcification. And mid-LAD has a moderate stenosis like this, some collateral from LAD to right coronary artery. So resting index measurement was 0.56. It's so quite low. So however, so it doesn't correspond with angiographic image. That difference merged. Why? In this case, left anterior descending artery covers the right coronary artery territory, so it results in high flow in LAD. So it leads to so overestimate functional assessment by resting index. It's a so mechanism. This phenomenon already published in so excellent paper. This paper compares the functional assessment before CTO PCI, after CTO PCI in donor coronary vessel. As you can see, IFR resting index and FFR was significantly improved after CTO-PCI in donor coronary artery. So we have to pay attention in donor coronary artery functional assessment in CTO-PCI. So recently, angio-based FFR was developed. Theoretically, these functional assessments could not be affected by high flow and collateral flow. Thus, this unique new technology is one of the key to overcome donor coronary artery functional assessment. However, clinical evidence is limited in terms of angio-based FFR. We have to further analysis, further data collection should be needed. So this is my take-home message. Coronary imaging is definitely advantage in CTO-PCI. It results in safety and high success. Wire-based FFR in donor coronary artery could overestimate functional assessment. Lastly, we sincerely thank for good friendship and strong relationship. Thank you so much for your attention.
Thank you, Dr. Yamanaka, for the really nice presentation. And then, of course, the use of imaging in physiology, especially in CTO, is relatively not so common. We also still learn how to maximize our IFUS in CTO. So that's why we learn many things from your slide. So thank you very much. You may have a seat. Or is there any one or two questions maybe before we move to Harapan Kita, Dr. Amir, maybe?
Yes, yes. Thank you very much, my friend. Yamanaka Sensei. I think my question is, how do you compare the donor vessel FFR before and after CTO-PCI? Let's say in your case is FFR of the LAD in CTO-RCA. Before and after, does it really, I mean, the reduction is or the increase is really high or just a small?
Can you push the okay.
Maybe theoretically, so before CTO PCI, so sometimes we can see high flow in LAD. However, so mechanical injection method is so nice, so we can see angiographically anatomy we can see very clearly. So it doesn't matter. So how to measure the FFR, angio-based FFR? It's so clear. If you have clear image, so we can obtain good FFR, angio-based FFR value. But so in previous cases, so we did not PCI for RCA, not yet. So next month we try. After that, so we check the LAD FFR, angio-based FFR. So that result we'll share in the near future.
Okay, I have a question. It's okay? I have a question. So
yes, please.
The IBUS guided antegrade approach is a quite nice method. However, the disadvantage is we need at least 7 French guiding catheter. So if the vessel anatomy was from the origin, it's very small. In that case, this method cannot work. And okay, it's okay.
Thank
Sorry.
you. Saito Sensei, thank you so much for nice suggestion. So, however, so in this clinical setting, we can use 7 French cylinder sheaths. So it means almost as same as 6 French. So, my opinion, it's less invasive for patient. I think so. Saito Sensei is spread so radial approach P cylinder radial approach PCI. So we would like to perform PCI like Dr. Saito Sensei.
How do you think about the use of how to say electrical IVUS?
Elliptical.
IVUS.
Elliptical IVUS. I'm not really familiar with that. Elliptical.
Anyway, at this moment, it's not on the clinical.
Oh, I see. Okay, we were waiting for the new modern technology that Dr. Saito mentioned. So since we already led of our time, so thank you very much, Dr. Iwanaka, for the nice presentation. Thank you. So we move to Harapan Kita. So because we must end at 1 p.m. Sharp, can we get the transmission from Harapan Kita, please? Yeah, bumper.
Okay.
The National
Mari
Cardiovascular
berkenalan
Center,
dengan Hub Gym,
Harapan
Rumah
Kita.
Sakit Jantung dan Pembuluh Darah
Supported
Harapan
by
Kita.
advanced technology
Tempat bagi
and a
kita untuk
world-class team of
mengembalikan
experts,
kondisi
we
tubuh
continue
seperti
to
sedia
deliver
kala
comprehensive
pasca
and
menjalani
integrated
tindakan
cardiovascular
kesehatan
care.
jantung. Karena sejatinya,
We perform
suatu
surgical
tindakan
interventions
dapat dikatakan
including
sukses
coronary
apabila
artery
kondisi
bypass
pasien
grafting,
dapat kembali prima.
heart valve repair,
Pasca
and minimally invasive cardiac surgery, using small incisions and precision techniques that help patients recover faster. We are also fully prepared to perform advanced cardiac procedures such as left ventricular assist device implantation, heart transplantation, and robotic surgery, marking a new milestone in Indonesia's cardiovascular medicine. Our expertise includes MitraClip procedures, the Bentall, and total arch replacement operations, and cutting-edge stem cell therapy for regenerative cardiac treatment. National Cardiovascular Center, Harapan Kita, stands as the leading hospital in Indonesia with the highest number of pediatric cardiac surgeries. Even pediatric interventions can now be performed without radiation exposure through a breakthrough approach called zero fluoroscopy, providing safety and comfort for children, expectant mothers, and patients requiring repeat procedures. We also provide non-surgical interventions such as rotablator, intravascular ultrasound, and optical coherence tomography, as well as valvular interventions like transcatheter aortic valve implantation, tricuspid valve procedures, and vascular interventions, including thoracic endovascular aortic repair, endovascular aneurysm repair, and endovenous laser treatment. In the field of cardiac rhythm disorders, we are proud to be pioneers in pulsed field ablation and leadless pacemaker implantation, offering safer, more effective solutions for arrhythmia patients. Our care does not end in the operating room. We support every patient's recovery through cardiac rehabilitation programs such as Heart Gym, enhanced external counterpulsation combined with the most advanced imaging facilities, including single-photon emission computed tomography, dual-source multi-slice computed tomography, magnetic resonance imaging, fetal echocardiography, transesophageal echocardiogram. All of these are integrated with comprehensive cardiovascular medical checkup, hemodialysis, palliative care, ensuring that every patient receives holistic, compassionate support at every stage of their healing journey. As a teaching and research hospital, we serve as a national center for the advancement of cardiovascular medicine. Through collaborations with University of Indonesia and hospital-based cardiology residency program, with scientific research, publications, and patented innovations, we contribute to shaping the future of medical science in Indonesia. We also serve as the hub of the National Cardiovascular Network, developing and strengthening standards of care for hospitals across the archipelago, from Sabang to Merauke. Our journey of transformation continues with smart building automation systems, modernization of kitchens, laboratory, central sterile supply department, and pharmacy. Along with the expansion of educational, nursing round, and research facilities. Through decades of dedication and commitment, we have received numerous national and international awards, a true testament to the quality, safety, and integrity of our care. And now, the construction of the Tokushukai building marks another milestone in our journey, a new symbol of progress and collaboration, bringing future-ready facilities to serve the next generation of patients. We are the National Cardiovascular Center, Harapan Kita. More than just a hospital, we are the center of hope, a place where life is given a second chance.
Keep believing in giving hope with a commitment to serve across generations.
All right, so thank you. Can we have, okay, there you go. So we already see, hi, Fujita Sensei. So this is,
Hi, Donnie Sensei. Yeah.
yes, this is Donnie, and we have a distinguished panelists here. So we have Dr. Shun Sawada, we have Professor Saito, we have Dr. Kai, Dr. Dafsa Jusar, Dr. Amir Aziz, and Dr. Hana. So please, Fujita Sensei, so what's your case, and Dr. Agnes, can you describe for us, please?
Okay. Okay, thank you so much. Okay, invite us. So today's operator, Dr. Fujita. Slide it, you.
Okay, my name is Agnes Sinar from RSUP Surabaya.
Okay.
Okay.
Thank you. And the very old, supported. Okay, thank you so much. Okay, please, presentation.
Okay, let me introduce the case. Next slide, please. Next. Okay, we have here 50 years old, previous, back. Okay, we have here 50 years old female, came with angina equivalent on daily activity. She has 3 coronary risk factors such as hypertension, type 2 diabetes mellitus, and dyslipidemia. And she never underwent any PCI procedure before. From her lab, she has mild renal dysfunction, and her ejection fraction is 41% with hypokinetic at all apical, mid-anterolateral, anterior, and anteroseptal. Next. Okay, from the ECG, we can appreciate here there is an old anterior MI. Next. Okay, next slide, please. Okay. From the coroangiography, we can see there is the total occlusion right after the diagonal branch, and also subtotal occlusion at the third. Okay, next, and normal RCA and also normal life mean. So we diagnose here with CAD2 vessels with cyto-LAD. The strategy will be explained by Dr. Fujita.
Okay, thank you so much. This case has a LED CTO with, from the diagonal branch. So unfortunately, so it means an angulity CTO, LED proximal cap. So today we plan to first see the diagonal, from diagonal branch to the IVAS check the CTO proximal cap, then try to the TDR. If the fail, TDADR. If the fail, retrograde approach. That is my procedures.
So can we have an angio, please, so we can see the angio?
Okay.
Okay,
Please.
there you go. Okay, all
Today's
right.
answer, please.
This was his engine.
Here.
Okay, there you go. We can see the angio look like, okay, relatively long, and also I don't see any stump. A very, very difficult case, I think, to find a stump there. So we have some panelists here. So Professor Saito, so what is your strategy in this difficult scenario?
Yes, this is a quite difficult case. So as Dr. Fujita mentioned, we just start from the antegrade approach and gradually via escalation, and then to failed, then go to the retrograde approach. And of course, we have to utilize the antegrade IVAS guidance technique as well. And that's all.
Thank you. So Dr. Fujita, can you show us what have you done for
Okay. You can see that this is Shineangio. Shineangio shows the LED CTO might be the contain the calcification. You can see calcified proximal cap. You can see calcified.
Yep. There's the calcified.
Calcified.
All right. Okay. We can see that.
Okay. Then next please. Then IVAS. Check IVAS. Then we can see I'd like to see IVAS. Okay, please IVAS. This is first IVAS. Okay. This is first IVAS. So this is from diagonal branch distally. So yes, no, more distal. Sorry. This is sorry. So first I directed advanced IVAS, but cannot cross. Then I tried the 2.0 bottom. After 2.0 bottom IVAS, okay, please show me.
Post balloon.
After 2.0 bottom.
Okay, you already penetrate. Okay, you already penetrate the lesion. So which wire you used to penetrate the lesion?
Yes. But okay. What is a proximal cap?
That one.
Okay, here. You can see. Here is the proximal cap.
All right.
Okay. Then I try to use next step is no IVAS guidance penetration wire. So NEHP 6 gram. This is a high chip load polymer jacket wire. Okay, please advance. Okay, then Next, please. Next, okay, insert. Then check angio. But small branch and some kind of LED can seem to be. Then I advance the guide wire. Okay, please. Next, please. But we can't advance anymore. So then check IVAS again. Okay, next, please, IVAS again. So you can see IVAS show that this is Corsair. IVAS going to the subintimal space here, not the LED. Then this LED wire ring is mistake. Okay. I negotiate another. Okay. Next IVAS. Next is the IVAS guided functioning. First, NHP 6 ground failed, so I direct this Dianex 3 is functioning. Okay. You can see here is the functioning side. Okay. Please show me the IVAS. This is Corsair. Then more distal. Okay. Wire going to okay. I try to enter this proximal cap. Then luckily I advance the Corsair, Gaia. Then I advance the Corsair. Okay, next please, Angie please. Okay, then HDR. Okay, you can see HDR shows us some connection. Yes, it is type 2A region. Okay. You can see? Okay. Connection. Okay, you can see? So, but unfortunately, I cannot cross. Contrast easily to cross, but guide wire cannot cross. Okay, next please. Next please. Wire goes the extra plug subintimal like that. Okay. So next please. Next. But unfortunately, we cannot. But in this time, so in Japanese doctor might use a Gaia something to using a 3D wiring. But in my opinion, so 3D wiring using a Gaia conquest without IBUS sometimes injure the adventure. So it is risk of the perforation. So I don't like to use a 3D wiring. Then next please. Next. Okay, please, proximal. More proximal. Okay. Then contrast injection. So this part is the extra plug, okay, you can see? Then next is a star technique. Okay, please, next. Okay, next. Okay. Then I use like a star technique, but unfortunately cannot cross. Then next. Then the IBUS guided repunction. Okay, next please. But very difficult situation because the proximal cap is very, very hard calcified. So advanced guide IBUS is very difficult. Okay. Then this site is a true lumen. Please show me the IBUS. Okay, here you can see. Okay, you can see IBUS. This is true lumen. Okay, and here side is true lumen. But unfortunately, from now on, enter the extra plug region. Then I stick the wire ring, TDADR situation. Next, please. But first, I use a Gaia SAT, but unfortunately, Gaia first is easily to slip. The next, please. 入ったとこあるか見しちゃっていいのかこれ
LAD true yang terakhir.
これ入ってる You can see IBUS. This is a true lumen. Then we enter the conquest ST, insert here. Then, please, proximal side. Previous IBUS, please. Previous IBUS. Okay. Okay, you can see. I try to IBUS some things, but a very, very difficult situation because this is from this extra plug. Then I negotiate wire from the left side. You can see this right side is true lumen, but angio coagulation needed. Then we rotate it clockwise. But so yes, you can see like that. Okay, more. Okay, it is okay. It is so from now on. I look out from 6 o'clock. Then I negotiate wire left side and anterior. You understand? Then I negotiate wire inside here. Okay. Then I can get the distal true lumen. Then switch wire. Okay, next please. Next please. Next か。取られたやつどれだ Next. これ this. Next please. Then switch the wire. Then this is Sean Black. Sean Black going to the distal branch. Okay, next please. Then this is a true lumen. Okay. Then next please. Then check angio. Angio shows a branch. This is a true lumen. Then how to treat in this situation? But now the patient no chest pain, no ST elevation so far. So my plan is very difficult because the CTO proximal cap is very hard. So some kind of preparation like IVL or cutting balloon. But in this situation, so the patient have not accepted the IVL, right? Okay. So we can use only the cutting balloon preparation. So that is my procedure so far.
Okay, yeah, like I mentioned before, it's very complex. Look like you penetrate the true lumen, but in distal part.
Yes.
And then some false lumen in the proximal and middle part. So we have a relatively long false lumen, right? So it's not easy to decide. I really understand. So I don't know.
Yes.
So I want to ask my panelists here, maybe Dr. Dafsa, what do you think if you have some situation like this? Should you dilate more and then put a stent, or just because of relatively long false lumen there? Please, Dr. Dafsa.
Thank you. Hi, Dr. Fujita, and I think thank you for showing your technique. This is I think it's a technique that's very hard to take a while to comprehend. But as Dr. Donny mentioned, I think from the IFUS we see there's a long subintimal crossing in the LAD, which is usually have a lot of side branch, which very important. So
yes.
In that case, I think we don't. Well, in my opinion, I think we don't want to stand all this vessel. So my approach would be to stand the proximal part where it is still in the true lumen, and then do a cutting balloon and just leave it as an investment to come again in 4 or 8 weeks.
Okay, thank you, Daf. Yeah, this is one of the strategy for investment. So, maybe from Japanese colleague, Professor Saito. So, what do you think? Should we do that, or any other strategy from your side?
Yes, this is anyway quite difficult cases. Only doctor is using this technique. And my suggestion is, anyway, we have to dilate as far as the balloon is reaching. And then I want to wait for 1 week, 2 weeks.
I think the Great Sila does not get.
Sorry, you can go now, or Dr. Saito, please proceed. Your comment.
After the balloon dilatation, of course, it's in the false lumen. Then I want to stop as far as my balloon reaching point. And then I want to angiography 1 week or 2 weeks later, and then maybe something may change. And then we can, shoot the different target.
So, Dr. Saito, you not suggest to put a proximal stent? No. Just balloon?
No.
Okay.
At this moment, no.
Oh yes. Thank you. Yeah, really nice discussion. It's not easy, I understand. So, okay, there is 2 comments there. Dr. Dafsa mentioned about just put a short stent in the proximal. Prof. Saito. Yeah. Prof. Saito mentioned that just dilate and then look again after a few weeks. So, it really depends. Dr. Fujita Sensei, what do you think?
Okay, this is true lumen. Okay, check. Okay, check. Just a moment. I check area of the subintimal space. Okay, this is true lumen. Okay, please pull back. Okay. I believe the false lumen area is not so long. This is true. This is true. You can see angio. This is true. This is true. Okay, you can see?
Yes, we can see that.
Yes, mostly interpret. Okay.
Now,
this is
I think it's false, right?
This is very difficult. But my opinion, the HDR show us interpret in here.
Okay.
So, but pull back. Okay. But unfortunately, very difficult situation because the calcification is very tight here. Okay.
Yes, yes, we can see that. We can see that. So actually, the false lumen is not that long, right? I think you what 24
Yes,
or
exactly.
20, less than 20 or 24. I think yes, is about that, right? So the big question will be: should you dilate more or even use a more aggressive one like cutting balloon, or I think rota is not needed because it's already dissection somewhere. So
Yes,
do
yes,
you
yes,
think to
exactly.
do the cutting balloon more, or you just happy, just leave it there? And so what do you think?
Me?
Because we have some
Yes,
several
yes, yes.
different
Yes,
opinion.
but yes, my opinion. Now we can get mostly intraplaque through lumen. So I hope to put a stent here. But unfortunately, so we cannot use IVF. So that is a big problem for us to put a stent. But you know, the Dafsa Sensei mentioned that extraplaque area not so long, not so long. Might be the 10 or 15 or millimeter, just LED proximal site. But mostly distal site is intraplaque. Then I take first I take a diagonal branch protection. Then how to put the stent from the just proximal LED to distal LED. And you know that this LED not so big from the RCA. So diagonal branch more important. That is my opinion. My opinion is not investment, put a stent.
Okay, okay. So what the next? Since you have some mark calcification there, so
Yes,
you want to
calcification.
dilate more with cutting, or do
Yes,
you
dilate
have?
more.
Okay,
Yes,
okay.
cutting around proximal site is okay. But please measure
Any
the
other
LED proximal site.
any other comment from our panelists here?
Sunglass. Okay, please give me the symbol. Then protein guide wire. Cutting variation.
Cyan black.
3.0.
Cyan blue.
Cyan blue, okay, thank you. You know, 3.0. 3.0 big. What? Insert. Now we plan is a LED proximal site or and LED bifurcation site using a cutting balloon.
Bang Ben. Insert tuh. Lihat insert tuh.
これ LED? そうです。You can see the IBUS. So this is the bifurcation of the LED to diagonal. So this more advanced. More distance. Okay, here is very danger. If you cutting well, stop. Okay, you understand? Just balloon is okay. Cutting balloon is dangerous because the sign happened. So that is a risk of the perforation. Using a rotor, cutting balloon. Yeah.
Okay, yeah. I've read about that. Some pointing that the IFOS can predict perforation if we do some more aggressive one.
Just proximal is prepare the cutting balloon is needed. Okay. Diagonal proximal. Here. 2.0. More proximal.
Okay, you want to
yes, here.
more. Okay. 2.0.
3.0.
Okay.
What
2.0.
size? 2.0? 3.3. Okay, we select the 3.0 cutting balloon, just proximal.
Okay, 3.0.
Okay, proximal.
Okay, you want dilate more with 2.0 cutting balloon, Fujita Sensei?
3.3.
Oh, okay.
Just LED proximal. Yeah.
Oh, wow, okay.
Okay.
Yeah, we have still have 4 minutes transmission, Fujita Sensei.
Okay, thank you.
So yeah, I think we can see more when you dilate the vessel.
Okay,
so see what happened.
Oh, diagonal branch crossing is very difficult.
Yes, yes, yeah, can understood. It's calcified vessel, and you
Okay, okay.
are already. It can be understood. Yeah.
Oh.
Okay. You use a Xeon black there, or what wire
Yeah,
you use?
Xeon black.
Okay, good.
But this is the branch. Please show me the angio, previous angio, apicorneal angio. Please show me the angio, previous angio. No, LED, just LED. Okay. Thank you. Oh,じゃあいいのか。It's okay.
Dr. Fujita, can I ask something?
Okay.
Yeah.
Check angio. Oh, just one. Okay, please go ahead.
Yes. Since this is a very long lesion of the LAD and also the distal part of the LAD is quite small, do you consider the hybrid approach for this LAD using DES in the proximal part, which is bigger, and the distal part with a long, probably DCB 225 or 25?
Yes, exactly. Yes, that is a good option. Hybrid approach. Okay, thank you.
Fluorosef.
Okay, please show me. Okay. Flow is okay ですね。This wire is broken. Okay. Please give me the cutting worm. This is diagonal branch ね。LED. cutting diagonal LED か。Okay.
This is diagonal.
You can see the. Please show me the angio. Previous angio. Okay, you can see the flow is okay.
Oh, you use integrate injection. It looks like it's already connected, right?
Yes. And you can see the septal branch. We don't we don't lost the branch. Okay, you can see.
Okay, good.
Septal branch.
Yeah, good sign.
Thank you so much.
Okay. Can you enlarge the angio so we can see? There you go.
Angio, okay.
Now we can see the angio.
Okay, repeat again, angio, please. Okay, please take angio. So,
Okay, great. So we can see the septal branch, especially in the proximal, and then some connection there.
Yes.
So what you want to do is just dilate the proximal one and put maybe one stent in the proximal. Is it your strategy, Dr. Fujita?
Yes. But put the stent proximally. This study is maybe a REEV or a DCB.
Okay. I think really good choice. Anyway, congratulations. You already penetrate the distal cap, and then look like you are in the true lumen, not very long, and then you will dilate and then do the stenting on the proximal one. Okay, then again, I'm sorry that I have to conclude the session because of the time transmission. Thank you very much, and congratulations, Fujita and Dr. Agnes. Ya, terima kasih. Okay, we close the transmission for Harapan Kita, and then again, I like to say thank you for all the panelists here, and then for the fruitful discussion. And by that, I'm closing our session today. Thank you very much. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor, and thank you to all speakers and panelists for the excellent presentations and discussions. We kindly invite to remain on the stage.
Bye. Say goodbye.
Bye.
To receive and gather for a group photo and token appreciation.
At this moment, we would like to extend our deepest appreciation to all sponsors who have supported the Indonesia International Cardiovascular Summit 2025. Our gratitude goes to PT Bank Mandiri, PT Boston Scientific, PT Bank BRI, PT Tawada Healthcare, PT Novartis, PT Philips and Berkaniaga,
PT Indosofa, PT Permata Bunda Artano, PT Revas, PT Metronic, PT IDS Med, PT Bank Syariah Indonesia. Thank you for your invaluable contributions and continued support in making this event possible.
Once again, thank you to all speakers and panelists. You may return to your seats.
Ladies and gentlemen, we have now arrived at our lunch break. Lunch has been prepared and available at the foyer area of the ballroom. All participants are welcome to enjoy the meal and take this time to relax before we continue with the next scientific session.
We kindly remind all participants to return to the ballroom by 13:55 as we will resume the program with the live session of arrhythmia. Thank you and please enjoy your lunch.
Para hadirin sekalian, kita telah tiba pada waktu istirahat siang. Hadirin sekalian dapat menikmati makan siang di area foyer di depan ballroom. Kemudian dapat kembali di ruangan pada pukul 13.55 dengan acara pemutaran door prize.